Good morning. Good morning. Good morning. Thank you. Good morning to our virtual audience as well. We're so glad you could all join us. And if my voice fails, read my lips. We have an energetic program again this morning. But before we get started, I want to thank everyone who attended the silent auction, donated items, purchased items, or simply enjoyed the evening with us. We raised over $4,000 to help support the programs. And some of you forgot to pick up your items. They will be laid out near registration. You can take another look. And a few items we didn't have bids on, so you have another opportunity. An important lost item, Swapna, who you met yesterday, has lost her conference bag, and it has her wallet and other things in it, important. So if we, pardon me? And Natalie lost her shoes. So if you find the bag, see someone. If you can't find Swapna, see me or any Oley staff member, and we will find Swapna. If you find flip-flops, they're not going to fit you. They're very tiny. Again, the same thing, bring them to Oley registration. Today is Raffle Day in the exhibit hall at 2 o'clock. Must be present to win, and only one win per family. So if you have 16 kids putting their tickets in, one will win. The other 15 are going to be unhappy. So let's get started. Let me get to the right day. We have a very good program. I can't seem to find it. Oh, I have 2 minutes. Oh, jeez. You're fired. You're annoying me. Okay. And things are not in the order they are in the program. Our first speaker is Heather Isley. And I met Heather at an intestinal failure symposium in Chicago a few months ago. And I was really impressed with the information she shared with clinicians. And I don't see her coming. Oh, now I see her. I can breathe. Good. So, and I believe you'll be impressed as well. She's on staff in the Department of Surgery at the University of Illinois in Chicago. Heather, come on up. Thank you for joining us on the tail end of her vacation. Thank you.
And is there a, Joan, is there a clicker for changing the slides? Where is it?
What are these?
Is
No?
this it?
I think so.
No.
Try this one.
There we go.
Oh, I meant to.
All right, yeah, there we are. All right, so good morning, everyone. As Joan was so kind to introduce me, my name is Dr. Heather Isley, and I'm a clinical psychologist at the University of Illinois Hospital and Health Sciences System. So to start off today, I just wanted to say that I've got no potential conflicts of interest or financial disclosures to report regarding this presentation. So my presentation today is on coping with chronic illness. So some of the things that I wanted to talk about today are common issues related to having a chronic illness, coping strategies when you have a chronic illness, and when to seek outside help for coping with a chronic illness. This presentation is geared towards both caregivers and individuals with an illness. I will be talking more at the breakout session specifically to caregivers and consumers later this afternoon. So this presentation is a little bit more general. I'm also going to bring in information specifically to home parental nutrition when it's available, but there isn't a lot of research on this area. So to start off with today, what are common issues when people are experiencing a chronic illness? So one of the first things I wanted to cover is that some changes in mood are normal. We do see that people have some increases in anxiety and depression when they're dealing with a chronic illness. Typically, these are temporary and mild, but they can last longer, become more severe. We see up to almost 2/3 of adults on home parental nutrition report experiencing some symptoms of depression when they're on for long term, so about 4.5 years average. And this happens because experiencing a medical issue can overwhelm your usual ability to cope. You're learning to adjust to a new normal. And we see that there are changes in family structure, in your social life, independence, feelings of control over your own body. For adults, there's changes in your role at work, for children in school. And this actually brings me to something I want to emphasize throughout this presentation, is that perceptions are important. How we react to and cope with situations depends on how we perceive it. So, for example, when a role that is important to us and how we see ourselves as a person is disrupted, whether you're talking about work, parenting, school, we tend to have a stronger emotional reaction to that and have more difficulty coping than when that role is not important for us. We also see that there are economic changes when you're dealing with a chronic illness. This could be because there's less ability to work due to illness or caregiving, as well as increased medical costs. Issues such as increased fatigue, more symptoms of illness, more time needed for medical appointments or caregiving can lead to less time for socializing. And then also, we do see that people's perceptions of their quality of life does decrease with a chronic illness, including when patients are on home parental nutrition. Now, this doesn't necessarily mean that their quality of life is low. It's just lower than it was before the chronic illness, and tends to be lower than when they're compared to people who don't have a chronic illness, which I think is understandable. So what are some of the factors that affect people's adjustment to a chronic illness? It includes the illness itself, how severe it is, how frequent, and how the magnitude of the symptoms, how well understood the illness is, as well as the predictability of the illness. People who have worse symptoms report that they have lower quality of life. The treatment complexity also affects adjustment. So how complex the treatment is, as well as the information that you have about the illness and the treatment. Also, how much of an impact the illness has on how you live your life impacts how you adjust to it. Your perceptions of the illness itself, how much control you feel like you have over it, as well as how well you feel like you can manage the illness. Support from others also affects our adjustment to an illness. Having more social support is an important coping mechanism. And also the type of coping mechanism that people use affects their adjustment. So we see that when people use avoidant or negative emotion coping styles, things like venting or blaming, that they tend to report worse adjustment than when they use an active coping style. And we can see that all of these things are interrelated. So like the research tells us that having a negative or avoidant coping style is associated with feeling like you have less control over your illness, and then you also perceive the illness as interfering with your life more. So what are some of the issues that we know from the research that specifically affect people who have home parental and enteral nutrition? We do see that they're more likely to have poor sleep from the equipment noise. It could be from having a sleeping position to avoid disconnecting tubing, or frequent urination at night. We also see that up to 90% of people who are on home parental or enteral nutrition report problems with fatigue. And this can be both related to the disease itself, depression, or it can go back to that sense of control over their symptoms. People also report difficulty traveling and socializing because of the equipment and learning to adapt to it. We also see that the change in meaning of food and eating changes when people are on home parental nutrition. So a lot of people will report that before they start home parental nutrition, that there can be a lot of anxiety around eating because of concerns about malnutrition, and eating really is just focused on survival. Once they do start home parental nutrition, the focus of eating can change to the goal of trying to reduce dependence on parental nutrition and increasing intestinal adaptation. So it's kind of more like eating for health. And then also, we socialize around food. And so once your eating habits have changed or you're unable to eat, it can be harder to spend time with others and increase feelings of isolation. We do see that people report that they have better quality of life when they can participate in social gatherings. And sometimes people will report when they're on home parental nutrition that food and going out to restaurants just feels like a waste of money. We can also see that when people are on home parental nutrition, that there's an increased risk of substance abuse, and this is specifically related to opioid pain medication if the underlying disease causes chronic pain. We can also see that there are issues around body image, depending on issues such as the type and location of the catheter. We can also see concerns about dislodging catheters and tubing can affect people's comfort in engaging in sexual activity. So what are some strategies for coping with chronic illness? And it really depends on what's important to you. There is no one size fits all when it comes to coping with a chronic illness. Our coping mechanisms are based on what is meaningful to us, and that varies from person to person. So what is a helpful coping mechanism for one person may not be for somebody else, and that's okay because we're all individuals. For the most part, it's not the type of coping mechanism that's important, but how you use it. Almost any coping mechanism can potentially be positive. Reading, watching television, exercising. The issue comes in is if you're using them to the point where you're avoiding important tasks or they're interfering with adequately caring for yourself or others, such as you're skipping medication or treatments, skipping medical appointments, engaging in less socializing. That's when they become problematic. So there was a study that came out that found that when youth with chronic illness used spirituality and focused on it in more in terms of comfort, that this was actually related to decreased distress, whereas when they were using spirituality in a more negative way, such as focusing on blame and guilt, that they reported themselves having poor quality of life, felt like their symptoms were worse, and had increased distress. So they're both using spirituality, but they're using it differently. So again, it's not what it is, it's how you use it. The only exception to that is that any coping strategies that involve self-harm or high use of avoidant coping strategies, so again, it's interfering with your functioning, those are always negative. So how do you figure out what your coping mechanisms are? The easiest thing to do is to start off by building on old, healthy coping mechanisms. So looking at what you enjoy doing and what is meaningful in your life. So whether you're a caregiver or a person with a chronic illness, what is getting in the way of you using those things? A lot of times when we have a chronic illness or we have a family member who has a chronic illness, we have to be creative about how we use these things. So if your coping mechanism was exercise and you can't make it to the gym 5 times a week for an hour anymore, can you do something like, take a walk for 20 or 30 minutes? Are there other ways for you to stay involved in the things that are meaningful to you? So you get a little creative. One of the other things I have people do is I tell them list out the things that you've enjoyed doing and the things that are meaningful to you, and then start looking for themes. Because when we know what it is about those things that is meaningful to you, then we can kind of take a step back and look for alternative ways for you to still have that value in your life. So the one I use a lot with patients is cooking. Some people really enjoy cooking, and if you're not able to do it or you're just not interested in it anymore, I say, well, let's take a step back and figure out what it is about this that was important to you. So for some people, it's a way for them to feel creative. Other people, they like learning about new ideas or new cultures, and their entry to that is food. Other people enjoy feeling like they're nurturing others, and they do that through cooking. So when we know what that is, if you can say, what I really like is to be creative, then that gives us a lot of other ways to develop additional coping mechanisms that still bring that value into your life, just in a different way. Also, one of the things that's really important is staying connected to your social network. Social support is a really important source of coping for a lot of people. And going back to the theme of perception, it's not about quantity, it's about your perceptions of the quality. I always tell people to communicate what you need to others. There's a lot of people out there that want to help, but they just don't know how. And I tell people, be as specific as you can with what you need. That doesn't guarantee that they're going to be able to do it. Telling somebody what you need doesn't guarantee that you get it, but they sure can't give it to you if they don't know what you need. Now, sometimes people don't feel like they're able to give that, and so in that case, you can say, well, then what do you feel comfortable doing? So somebody may say, Wednesday nights are a really busy night. It would really help if somebody could help make dinner for the rest of the family that night because, I'm usually at medical appointments late. And so the other person may say, I can't do that, but I can help in this other way. Or sometimes they'll say, yeah, I can do that. Again, people can't help if they don't know what kind of help you need. I also wanted to make a brief point about social media. While staying connected to others, experiencing similar problems is helpful. Again, it's like any other coping mechanism. It depends on how you use it. It can be really helpful to see what other people are going through, but be aware that you're getting snapshots of their lives. And what tends to happen in social media is we compare our worst to their best. And so a lot of times it can end up making us feel worse because we feel like we're not coping as well or we're not doing as well as other people. So, so it's something to be aware of, that when you're seeing posts from other people, that you're just getting a snapshot of their lives at that moment. And also be aware of what you put on social media. As long as it's out there, even if you delete it, it's potentially discoverable. So that's also something to be aware of. And when it comes to coping, I tell people, use what works for you as long as it works. Once it no longer works, then it's time to take a step back and reevaluate to find a new way of doing that coping mechanism, or maybe it's time to look for a new one. But you use it as long as it works. And I wanted to briefly say, so what does the research tell us about coping with chronic illness? Focusing on your strengths helps you to feel better about your support system and helps you to feel better about problem solving. You feel more in control when you're focusing on your strengths. Active coping styles like problem solving and seeking emotional support are related to better adjustment, better mood, and better perceptions of your quality of life. And finding the meaning in the situation. And this is not every cloud has a silver lining. I hate that. We can make meaning from difficult situations. And the research is actually called things like post-traumatic growth. But it's about looking for, maybe it is finding your strength in a difficult situation. But this is going to be really individual to you. And so why is coping important? Why am I up here talking about coping? Thinking positively will not change your illness. I tell my patients, what we do in therapy is not going to change the reality of your illness. But what it does do is helps you to feel better emotionally and helps you to live a more meaningful life according to your values. Yes, increased stress can exacerbate symptoms, but positive thought doesn't change the disease. What it does help with is it can help us to better manage our illness. When you feel more in control, when you're coping better, you're feeling more in control of your illness rather than the illness feeling like the illness is control of you, it is easier to stay on track with managing your illness. Things like depression or feeling out of control around your illness makes it harder to adhere to the treatment, which then can result in worse disease symptoms. So again, it comes back to perception. And adjusting to a chronic illness, it's a process. It's not a one-time thing. I think we've all seen books and movies where someone has this epiphany and they come to perfectly accept what's going on in your life, and that works great in books and movies. It doesn't actually happen in real life. In real life, acceptance ebbs and flows, and that's normal. There are times when you're more accepting, there's times when you're less accepting. The overall goal is to get you where you're more accepting most of the time, but nobody's ever going to be 100% accepting 100% of the time, and that's normal. And when I talk about acceptance, I'm not talking about a passive process where we just kind of sit back and we stop living our lives because of an illness, but it's an active process where we work around it to continue to live a meaningful life for ourselves. The example that I always like is you're trying to get from point A to point B, and somebody sticks a big boulder down in the middle of your path. If you keep trying to bash through that boulder, you're going to end up hurting yourself. Whereas if you can say, you know, I really want to get to point B, let's find a way for me to get around this boulder. Let me tunnel under it. Let me climb over it. You're still getting to that ultimate goal of living a meaningful life for yourself, but you're working around this reality in your life that's making it harder to get there. So when is it time to seek help? So this is the one that most people will probably never need, but it's really important, so I put it in first. If you're ever having thoughts about harming yourself or someone else, if you're not sure you can keep yourself safe or keep others around you safe, then it's time to immediately go to the closest emergency room. They'll help stabilize you psychiatrically and get you started on treatment immediately. There's no possibility of you getting better if you're not here. But most people will never need to use that. But when is the time to start considering psychotherapy? You know, if the depression and anxiety you started experiencing with the chronic illness is not getting better and is now starting to affect your daily functioning, such as having a harder time completing tasks or missing out on work or school or social activities, for reasons other than symptoms, like you could go and you're not, or if it's interfering with your medical treatment, that's time to start thinking about therapy. You don't have to wait until you're so depressed that you can't get out of bed or you're so anxious about your health that you can't leave the house. In fact, the sooner that you get help, the easier the symptoms are to treat and the sooner you feel better. If you're consistently feeling overwhelmed, sometimes feeling overwhelmed is normal. And that's even if you don't have a chronic illness, it's going to be more often if you are having a chronic illness. But when it's frequent, when it's happening, when it's persistent, when it's lasting for long periods of time, that's the time for you to consider getting help. And what do I mean by frequent and persistent and long? Again, that's perceptions. That's up to you. When it's starting to feel unmanageable to you. Or when your usual coping mechanisms just aren't helping or they're starting to interfere. That's the time to meet with somebody to review how you're coping and start looking for ways to adjust that or look for new coping mechanisms. And this can just be a few sessions. You know, one of the roles of therapy is to have a safe place to talk about what you're going through with no judgment and without having to worry about how others are going to react to what you say. A lot of times as a therapist, I may be the only person who knows every bit about what the person is going through because they know they can tell one person one piece of information and another person another piece of information, but they're worried about what if they talk about this with that person. This is a place where you can come and talk about whatever you need to without worrying about how the other person will react. So how to seek therapy? I put some options up there of different ways to find therapists. All of these are suggestions. If you're contacting an organization, ask if they have any health psychologists associated with them, or if they have a referral list of psychologists who are familiar with your illness. A health psychologist, a general health psychologist, may not be familiar with your particular illness, but they should have a better familiarity about what it's like to cope with a chronic illness. And don't feel that you have to find one therapist and stick with them for the rest of your life. There's a lot of therapists have a lot of different personalities. There's a lot of different ways about approaching therapy. So sometimes it takes some time to find the right fit. So in summary, some temporary changes in mood are normal when you have a chronic illness, and the chronic illness is going to impact your life in many different ways. However, one of the things that's really important is your perceptions and the impact of your coping. That is one of the areas where you have control. And the coping strategies are going to be individual to each person. And so just because something works for one person, it may or may not work for you, and that's okay because you're a different person. And then finally, help is available if you need it. Therapy doesn't have to be long-term. As a health psychologist, I meet with a lot of people for a few sessions. I work with a lot of people who've normally coped with the stresses in their life just fine, but with a new complex health issue, they could use a little bit more support in order to help them feel more in control of their lives and to help them feel like they're living a life that's meaningful to them. And so a lot of times it is just a few sessions. Sometimes it's longer, but again, that's going to be up to you and what you need. So, any questions? Okay, at what age is it appropriate for you to start seeing a health psychologist? I'd say any age. I work specifically with adults, that's my background, but there are pediatric health psychologists as well. And if you feel like your child is having difficulty adjusting or just could use an additional source of support, anytime, there's no limit to it.
I just wanted to say that we do need to remember that we can have one person in the family with that chronic illness, but all of these things apply to the siblings, and that the mental health aspect is a huge part of it to make it through those things for everybody within the home.
Yeah, and that's why I tried at the beginning to mention that this was kind of specific to this was not specific to consumers or caregivers or family members, that I tried to keep this as general because yes, any of this can apply to anyone in the household. That chronic illness affects the whole family, and it affects different people in different ways, and it's not just based off of your role in the family like a sibling or a parent, but there's so many other factors involved.
Dr. Isley, I'm not quite clear whether you actually deal with a lot of families that are dealing with the kind of therapy that's being looked at here.
So I am a generalist health psychologist. I work with people with all different types of health issues. And so I haven't worked extensively with patients with home parental nutrition, but I've worked with people with all types of chronic illness, including illnesses that affect
The reason
eating.
I ask is this, because there has been a lot of studies in the, particularly in the parenteral area, and the findings are that if the person has been very ill and suddenly gets on TPN and begins to feel stronger and recover, then they have a very quick response to the limitations that they don't go into a serious depression. If on the other hand, yesterday they were fine and tomorrow they have an infarct which they were not expecting and suddenly they're told they're not going to eat again normally, then it's an incredible depression. And what we really need, if you have access, is what we really need is to know exactly where the ball is for people at 5 years, 10 years, and 15 years. Because there must be a whole process going on which fluctuates and changes, but many of these people are incredibly independent and making incredible contributions. So I think that picture would be very helpful for this audience.
So in the psychology literature, there is not a lot of information. I've looked in both psychology databases as well as medical databases, specifically on home parental nutrition and enteral nutrition. I couldn't find a lot of information. I have included everything that I could find that was relevant today. But those longitudinal studies of checking in on people a year out, 5 years out, 15 years out, there's nothing that kind of spans that. You'll get some research. Yes, absolutely. Absolutely.
Yeah, I was wondering, you said that active coping styles are associated with better adjustment. And I was just wondering if you would give a few examples of like what are some of those active coping styles or type of things versus the passive ones. If you could just expound upon that a little bit more.
Sure. Active coping styles, as I mentioned, like things like problem solving, things like going out and seeking emotional support from others, looking for those things that you enjoy, those things that are meaningful to you, staying connected to those types of things are more of the active coping styles. The avoidance, I think, is kind of self-explanatory. There are different ways to avoid, or the negative coping style. So when you're talking with others, you're just doing things like venting or blaming. You're not seeking, because again, that comes to how you seek emotional support. Then affects, whether it's a positive or a negative coping mechanism. So if you're just looking for a way to kind of negatively vent, and that's not to say that just being able to express yourself is important. But if you're not you're not doing it in a way that allows for positive feedback or positive support, kind of, I don't like to use this word, but just kind of the complaining. It doesn't say that you should never talk about the things that you're going through. That is important. But how are you doing it? Are you doing it with a way to try and get positive reinforcement from others, or are you doing it in a way that doesn't allow others to kind of give you that social support?
How would you recommend that other healthcare providers that don't have your expertise or family members bring up to someone that they may benefit from seeing someone like you?
So I always find with communication that focusing on behaviors is helpful. Hey, I've noticed that you're not going out and spending as much time with friends. I've noticed that those times when we have asked you to go out, you haven't done it, or you're not doing those things that you usually enjoy. It seems to me like maybe you're having a hard time coping. Is this time to think, what kind, so it could be a combination of what kind of support can I give, but then also, is this time for us to consider having somebody to talk to help build up your coping mechanisms? But keeping it very specific on the behavior, because then you're showing people that you're paying attention to what's going on in their lives, but it also tends to be easier to hear when we focus on specific behaviors rather than you seem depressed. That can make some people feel defensive, but if you can give them specific behaviors that you've noticed that have changed, that tends to make it easier for people to hear.
My child was put on TPN and HPN at 3 weeks. And so I needed help when he was about 3. But I didn't have anybody to take care of him so I could go to see anyone. Mm-hmm. So my husband was a pilot, and he was gone all the time. And so I went to a 12-step program at a big church, and I was there 3 years, and I was totally recovered after 3 years. And there was no charge, and they took him in their child care facility, so I didn't have to worry about child care, and it was totally free.
That's fantastic. I'm glad that you were able to find that. I know depending on the age of the child, sometimes therapists will if there's no other options for caregivers, that sometimes parents will, or therapists will let the parent bring the child. The issue with that is you're not then just focused on what's going on in the therapy session. It's also having to kind of watch them. And at a certain age, then they start understanding what's going on too. And so it can make the person feel like they have a little bit more difficulty talking about their feelings in the situations. But you can always talk, if you are interested in therapy and you don't have childcare, you can always ask them, hey, what are the options? Are you okay if I bring my child with? Depending on the age, maybe they can sit in the waiting room while you have the appointment. So talking with the therapist, and depending on the organization they're involved with, they might have options for childcare during that time.
Thank you very much. And you have a breakout this afternoon.
Yep. Yep, and I have a breakout session for caregivers and for consumers this afternoon.
It's in your program. Thank you. Thank you so
And
much, Dr. Eisele. Thank you. I just wanted to end this portion of the program with a note, and the note is that there was an NIH-funded study out of the University of Kansas that looked at people connected to the Oley Foundation and those who weren't. And the result was people connected to the Oley Foundation suffered fewer catheter-related bloodstream infections, less depression, and overall better quality of life. That's my pitch, to take people in the room and the virtual audience and get people helping us spread the word that the Oley Foundation is here and the impact is great. So thank you very much. I'm always finding ways to plug that in. Our next presenter, Lisa Epp, sharing her expertise on a trend to blend. Lisa is from the Mayo Clinic. She's probably familiar to most of the tube feeders here. And she's a member of the Academy of Nutrition and Dietetics, as well as the ASPN, American Society for Enteral and Parenteral Nutrition. And she's a well-known speaker on the topic. Thank you for coming. And it's her first meeting. Welcome her warmly.
All right, well, I'm going to just start out with a story because I think stories are memorable. So I've been at Mayo for 15 years, and maybe after about 5 years, I had been seeing a patient every year. And he said, you know, Lisa, I'm really stable. Why do you make me come back every year? I'm doing the same thing. I don't think I need to see you anymore. And I'm like, yeah, you know, you are really stable, but we still recommend you come back. I said, but is there anything that I could make better about your tube feeding experience? And he thought about it, and he kind of looked around. He's like, any way you could get me a bigger tube? And I said, well, why? Are you having problems? It's just those sardines will not go through the tube that I have. And I thought, what do you mean sardines? Well, I know I've been telling you I take 6 cartons of X formula per day, but I actually haven't done that for the last 3 years. And I thought, okay, I've got a lot to learn. So that's what I'm here to talk to you about today. I think a lot of you are familiar with blending and some of the new commercial blenderize formulas that are on the market, but those of you that aren't, I just kind of want to give you an overview of maybe some of the things you've been hearing about. Okay, I have financial disclosures here, but I will not be using any non-evidence-based recommendations in my talk today. Okay, so I just want to take a little bit of time to kind of talk about who is blending, what percentage of people at home are blending, talk about some criteria that you might want to consider if you're thinking about doing this, some tools that you need, looking at how would you make a recipe, and then lastly, just briefly talk about some of the formulas that are on the market. So we wanted to look at who was blending, because after this experience, I thought, oh, this is kind of cool. Maybe there are more people doing this than I thought. And of course, the physicians that I work with said, no way, people don't do that. This is just one person that told you about that. And I thought, okay, well, can we at least survey our patients and find out who is blending? And basically what we found out that half of our patients were using some kind of blenderized feeding. And that 90% of the people that we surveyed said, I would want to do this if you taught me how to. So that was very eye-opening to us, but it was also kind of one of those things where people thought, well, yeah, but you're Mayo Clinic, your patients are very savvy, maybe more of your patients that are doing this than outside Mayo Clinic. So with this survey, we did kind of start to look at, you know, is commercial formula better tolerated or is home blenderized formula better tolerated? And in this population, we did find that kind of one of the reasons why people were using home blenderize is because they felt like they were having less negative GI symptoms like diarrhea, reflux, vomiting, things like that. So then we wanted to look at a little bit broader audience, again, a savvy population. However, we wanted to look at pediatrics and adults, and actually of the respondents of this survey, which we sent out through Oley, about 90% of the pediatric respondents were using some type of blenderize feeding for a large portion of their nutrition intake. And these kids were growing 90% of the time versus, 50 to 60% maybe weren't growing or were growing well just on a commercial formula. From the adult population, we saw more 65, 66% using blenderize feeding for about half their intake, and only 67% were making their own food. So those might be some of you in the audience. But again, just reporting less weight loss or better weight gain with using some of the home blenderize formulas. So kind of the takeaway from this is we felt like, yes, a large portion of people are blending, but also potentially commercial formula was more likely to lead to weight loss or no weight gain versus home blenderize. So after we had these pieces of information, we thought, okay, we better get on the bandwagon and figure out kind of how to assist people so people who are interested in this can have a place to come to get resources. I'll just touch on this briefly. So this was a larger survey that we did and we had about 1,500, 1,600 respondents that we sent out through Oley, Feeding Tube Awareness Foundation, but also Quorum and Pediatric Home Services helped us kind of connect with people. And these are the numbers that we gathered from that, more like 15 to 25% of people nationally using blenderize feeding. So that maybe is a little bit more realistic of the general population versus savvy consumers like yourselves. So the takeaway really for clinicians and for patients and caregivers is that many people are blending, and really clinicians, your clinicians that may be refusing to help or find you resources to do this could be leading to patient harm, because then you maybe feel like you're on your own with no type of support. So just a couple responses from our patients. I have more energy with blenderize feedings and regular bowel movement. It's great to have flexibility and choice in the way I feed, and I feel the best I have in 10 years. You can't argue with that. So if you're thinking, maybe this would be for me, some of the things that we recommend thinking about ahead of time would be talking to your primary care provider, just to let them know. Don't be like my patient and for 3 years tell me you're using a product that you're not using, just so we know exactly what's going on. We do recommend that you have a mature stoma, not a brand new tube, just in case the tube does clog, so it's safer to replace the tube. However, there are some situations where we do blenderize through a brand new tube. 12 French or greater size tube is recommended. However, some of the commercial blenderize formulas, as well as thinner home blends, have been shown to work with smaller tubes and be able to work with nasal tubes as well. Have a system for monitoring, so when you get started that you have someone to follow up with to make sure this is going well. And then lastly, having a nutrition professional available so they can help you kind of troubleshooting and make sure that you're getting the nutrients that you need. So in kind of looking at what are the benefits, this might be kind of where you could hear from your primary care provider, why would you want to do this, or how can this be better than the products that might be on the market? So this is a survey of about 2,500 dietitians, and about 60% of them were recommending blenderize feeding, and it was mostly because of parent request. So that's still a lot of dietitians that really maybe don't know a lot about blenderize feeding or aren't using it in their practice. And this was concerning to me that 50% of parents were using a dietitian for helping construct recipes and monitor growth in their child. So that's one of my missions, is to change that. I want all dietitians to be open to assisting patients and family members with doing blenderize feeding. Otherwise, we know they're going to just do it on their own without our help. I have a list of studies that have been published in peer-reviewed journals here that just talk about the benefits, the clinical benefits of using both the commercial blenderized formula as well as home blenderized feeding. And basically listed here: improved reflux, decreased vomiting, improved bowel regularity, including less diarrhea, having more good bacteria in the gut, and even helping with bowel adaptation in short bowel, in children with short bowel. So you can see the references I have there, but it's a small body of evidence, but it is growing. And sometimes these are things that can help to bring to your healthcare team to say, this may be the reason why I want to try this for myself or my family member. There are some hesitations, I think, amongst the healthcare community about home blenderized feeding especially. And the top one there is limited research. So I gave you those maybe 6 studies there, and those are the 6 studies that I'm aware of. However, you could argue, do I need a study to prove to me that food is healthy for me? Maybe not. I think some people worry about microbial contamination, though, you know, a lot of the studies that have been done on microbial contamination of home blenderized feeding were done in hospitals where it was very warm, where they had poor practices in the kitchen. And so I personally don't think that our hospital would be at risk for that. And I feel like even my own kitchen would probably be a different story as well. So I think it's hard to really put a hard stop on that just from those couple studies. It is harder, though, to figure out what is in the blends. You know, it's easy to look on a carton or a container and see how many calories and calcium and protein and all those things. So clinicians think maybe it will take a little bit more of their time. Potentially cause reimbursement issues if you're not ordering commercial formula, and I can answer questions about that at the end if you have them. Possibly tube clogging more often, or tube wears out more quickly, so it does need to be changed. Maybe more difficult to travel, but maybe easier to travel. And you might have a hospital that doesn't support it. So if you went into the hospital and you were using home blenderized feeding, you would maybe want to have a backup plan if your hospital didn't allow you to bring in your home blends. So here are some of the tools needed. A healthcare professional interested in helping you with blenderized feeding, some resources for developing recipes, and a good blender. We did look at some of the blenders on the market just so we could figure out which blenders did kind of work best with blending food for tubes. And basically what we found out that Blendtec and Vitamix worked very well, but the Ninja really came in a close second. The other blenders that might be less expensive, like this Oster blender or even a food processor, the longer you blended things, the better it worked. So that would be a possibility as well. You might just have longer blending time with a blender with not a strong motor. The O-ring catheter tip syringes seem to work best because they don't get as sticky. Having straight bolus connectors for your low profile tube instead of the right angle can help food flow through more easily so it doesn't have to go around the corner. Using a large bore gravity bag rather than the small bore gravity bag can help food move through more easily. If you're using a pump, the Enterolite Infinity seems to work the best. However, you may need to increase the rate to compensate for the pump slowing down because of the viscosity. So for example, if you set it to run at 60 milliliters per hour, it may only be running at 50 milliliters per hour because of just the thickness of the formula. So you may have to set it to 65 or 70 to actually get the total daily volume in. So just being aware of that. Another option for administering would be the Boley bags to put the home blenderized feeding in and then administer with this extension set that's connected. So it's just food and water. I don't like to look at the home blenderized feeding as formulas. It's just food and water. You just eat it a different way. This is making me push the button like 3 or 4 times to go forward. So what would be some ways to decide how what foods to put in your recipes. So we could use exchanges, we could use a standard recipe, or we could use the plate method, which is my favorite, I would say. So this is an example of what I would consider exchanges. For example, in 500 calories, to have kind of a diverse food variety as well as good carbohydrate, fat, protein, basically you could choose a half of a cup of starch, and I gave some examples there, a fourth of a cup of yogurt, some milk, oil, fruit, vegetable, and meat. And essentially, if I was cooking lunch, I would just look at, okay, I'm having spaghetti, so I'm choosing broccoli and peaches and spaghetti noodles and meat sauce, and I'm adding a little oil and milk, and then that would be how I would make kind of the exchanges, versus if I was making breakfast, I might do oatmeal and fruit and egg and something like that. So this kind of gives you an idea of way to build a 500 calorie recipe with different foods that might be on hand. This is just a recipe that we have for hospital, a standard 1,000 calorie recipe. I don't recommend using the same recipe every day because food variety is beneficial, but it is an example of a recipe that we use in our hospital for a standard recipe. My preference, like I said, is using family meals. So going to myplate.gov and looking at, okay, I'm getting 1,800 calories from my commercial formula right now. I want to try doing blenderized feeding, so I need 1,800 calories. You can actually get these worksheets on the government website for the different calorie levels, and it would tell you then how many foods you need from each food group. So you can see here like 1.5 cups of fruit, 1.5 cups of vegetables, how much protein, how much fat would be a way to kind of build your daily intake. All right, so what would be some things to consider? I think we really get excited when we think, oh great, I'm gonna give my family member or myself a blended food. I've been on the same commercial formula for a long time. I'm so excited about this. And then people wanna do a lot of fruits and vegetables, which is great, but sometimes we forget about the carbohydrate or the water or the fat, and so sometimes we get a little bit too much. Sometimes we get too much protein. We think, oh, I'll add protein powders and all these things, and this is gonna be great. I'm gonna, get so much more protein than I was getting before. But if you're using meat or eggs or milk, I think you are probably not going to need an extra protein supplement. In general, these home blends can be low in potassium and sodium, so sometimes we do need to add salt. However, one of my preferences really is just to use condiments as I would if I was eating things by mouth. So if I was making a hamburger, for example, I would put pickle and ketchup and mustard in there, so I was getting some sodium and potassium, or I would put ranch dressing on my broccoli when I was blending it so I could get some salt from that rather than just adding salt. Sometimes we can get too much water in the blend because we're making it too thin. But sometimes we can also not have enough water because a lot of the standard formulas that are out there on the market have between 65 and 85% water, and most home blends have more like 65% water. So therefore you might need to do extra water boluses, and sometimes that can be forgotten because you're used to getting the water from your formula. So I just wanted to let you know that this market is definitely increasing, and I feel like every month there's a new formula, so I hope I have all of them on here that are currently available to you. But these are all different formulas that contain real food ingredients or blenderized food. And I think it's just important to know that because kind of like I talked yesterday, nutrition needs change over time, and something that's working today might not be working next year or in 2 years. So it's great to have choice and variety for every situation, and these are some of the options that you have. So my takeaway message is, and I feel like I'm preaching to the choir here, but it appears that blended formula is being used a lot, and especially among savvy consumers. We're finding a lot higher percentage of use. Definitely can meet the needs of a patient's nutrition with the help of a registered dietitian. And there's many options available. And so if you try something and it's not working, there might be another option. And there's lots of combinations. You know, some people might use, you know, breakfast and lunch is their standard formula, and then they blend their dinner with their family every night. There's no right or wrong way of doing it. So with that, I will open up to whatever questions you all have.
If you were to do blenderized formula over an extended period of time, how do you handle keeping the blenderized feedings from going bad?
Good question. So we use just standard food safety guidelines, which are food should not be kept at room temperature for greater than 2 hours. So if you're using a home blend and it's continuous, obviously that makes things more tricky. But we do really recommend that you only put 2 hours worth of feeding in the bag at a time, which sometimes for some of our patients is why they use a commercial product maybe at nighttime, because obviously you don't want to get up every 2 hours to refill the bag, but then just putting 2 hours worth in during daytime hours.
Way over to your left.
Okay.
I'm also a dietitian, and so this should come naturally, right? I mean, we know how to do this, and I had a patient come to see me, and she taught me so much. And then I got together with Lisa, so I want to remind you guys to look in the Oley Foundation archived newsletters.
Yes.
And I can't remember when that was. It seems like it was last month, but I'm sure it's a year ago. But we really detailed. Lisa was a big part of this, myself, Cynthia, I think Ann, all of us got together, and we detailed what she said, because it's hard to do. She's got it, so I'm so glad she was part of this, but it's difficult. So do you remember when that was, Lisa? Was that like January?
I
can
feel like
speak
it
up
was
to
last
that.
October.
Last October. Oh, you know what? I think that might be right.
It's on the website. If you go to the landing page for tube feeding, which has lots of great links and resources on tube feeding, there is the article about how to do it, as well as a webinar that Lisa starred in that was wonderful on blenderized tube feeding.
And some good
Thank you for
recipes. So
mentioning
that, it's just not easy, and that will really help you. But I think working with a dietitian is important.
We've also identified that you can get a discount on the Vitamix blender. Pardon me?
You have to apply to
apply.
get the discount.
Is that on our website? Information about applying?
I believe
or-
it is.
Okay.
I think there's a link.
They've changed things recently, so it's best to go to their website and to check. And they're doing some work with some children's hospitals too on the best way to blend and how to bring it into the hospital.
We did continuous blended food through an infinity pump for over a year, so if anybody has any questions about that, about keeping the temp correct, we were able to use the lab ice packs that you sometimes see, the real thick ones, and those do fine overnight. We temp the food, and it was the same, the next morning as when I put it in out of the fridge. So if anybody has any questions about that, you can find me.
Hi. So our son currently is 100% TPN, and we just do a little bit of Elecare overnight when he can tolerate it. But, we've been interested in trying to do some blended feeds and introducing it to him. He has a jejunostomy, so is there certain formulas, how different parts of the intestine absorb different things? Is there different recipes for somebody that would have a jejunostomy versus somebody with a longer segment or something like that?
Not necessarily different recipes, but obviously an awareness of absorption. The one study that I have linked there was actually a study of 10 kids with that were on TPN and elemental formula, and it's about gut adaptation. And so they used a commercial blenderized formula in that study first before they started home blends. So I would maybe take a look at that, and I can talk to you just one-on-one too after.
For the commercial blends, is it hard to get insurance?
Good question. The question was for the commercial blenderized product, is it hard to get insurance coverage? And I guess the short answer is yes, unless you have a clinician who is familiar with how to document medical necessity of those. So, different state insurance programs are different, but I'll just mention Medicare, for example, because I feel like they're the strictest. So you do have to document medical necessity by documenting a failed trial of a standard formula. And the way I have done that would be, decrease or need for reflux medications have increased with commercial formula, therefore needs a blenderized formula, which has led to decrease in reflux medications, or more constipation or more diarrhea on a commercial formula, therefore needs a commercial blenderized. So it's not an extensive, process, but you just need to have some kind of medical necessity rather than saying the preference is for a vegan formula. Unfortunately, most insurances don't care about that. They want to hear the medical things, and there's maybe about 5 things that I have been able to use for that, and so you do kind of have to have a clinician document that for you.
Well, that's it, Lisa. Thank you. Great job. Great job. I want to give a shout out to our AV people straight from Albany, New York. They're in our backyard. We're so happy we found them. Magic Wig is the name of the company, and they are absolutely wonderful. So thank you. They're also, in between sessions, willing to film some testimonials. If anyone is willing to spend 5 minutes with them, answer a few questions, we will use these clips here and there on our website or at programs just to kind of promote the Oley Foundation and the good things that not only we bring, but the information that we bring and the connections people to people. So this program this morning is a little Mayo heavy. I'm going to invite Dr. Manpreet Mundi to join me, and I'm going to skip down the laundry list of accolades here, but he's currently Associate Professor of Medicine, holds the leadership position of Community Core Group Chair, Outpatient Nutrition Core Group Chair, and most importantly, in this laundry list of just wonderful things that you've accomplished, he's an Oley board member. So, welcome. Thank you.
Well, thank you for having me again. I'll get started. And what I've been tasked to do this morning is to talk about lipid emulsions and try to explain, many of you have heard that there's a new lipid emulsion that's come on the market, and try to explain what the challenges have been with previous lipid emulsions and what the advantages are of both systems. So that's what I'll try to do, and I'll take us back a little bit looking at the history of lipid emulsions, why it's been so hard to develop one that's safe. Many of you on TPN, it's now a common occurrence that you're using lipids. Then go into, well, what are the complications that can be associated? Why are we picking the different mixtures that we are? So with that, I'll start with the history of lipid emulsions. And when we look at this, really the first sort of documentation or reporting on lipid emulsions started to occur in the 17th century. It's a tough read because Dr. and William Corton was doing a lot of work in animals and a lot of these experiments, such as providing intravenous olive oil to dogs, who then eventually had a lot of issues and passed away, including respiratory distress from the fat emboli. It's a tough read, but it makes the point of how difficult it is to mix oil and water and to do this safely. But this is where we started. Then in the 19th century with the cholera epidemic, there were so many individuals who were just dying from dehydration. There was this push to develop better IV solutions. And Thomas Latta and Edward Holderd published some of their work in that regard, with Edward Holderd kind of describing IV milk infusion in 3 patients. 2 of them actually survived, but again had some adverse effects from that fat being provided and not being soluble. So you can see how difficult this challenge has been. In the US, in the 1950s, we did have a cottonseed oil-based IV lipid emulsion. Initial studies, was felt that the reactions could be minimized with this solution, but unfortunately that wasn't the case, and it was also pulled off the market. So you could see we struggled for a long time to have one that's safe and usable, which then led to the development of a soybean oil-based intralipid. And this is what in the US we've then had for many decades. It's a combination of soybean oil with the use of egg yolk phospholipids to make sure that this oil then stays solubilized in that water solution. Glycerin is also added to it. And this is what we've used for a long time. Prior to it being developed, and I want to highlight some of these cases, because of our experience with cottonseed oil, in the US, when we look at Dr. Dudrick and his famous experiments in developing a safe parenteral nutrition solution, those solutions were predominantly dextrose, so carbohydrates, and protein. We did not use lipid emulsions, and many of the patients, especially our younger patients, were developing essential fatty acid deficiency. That's what the picture shows here with the scaly skin that you can see. In Europe, with the introduction of intralipid or soybean oil, ILE, they started to use it right away, but we didn't. So we had many issues that came about, and these issues are occurring. So a little bit about the physiology. I won't go into this too much because it's quite dense, but essentially when we're talking about oils and lipids, and someone brought up a great question yesterday in our session, what we're looking at is a short chain, medium chain, long chain, and very, very long chain fatty acids. So I've kind of labeled that there. 1 to 5 carbons is typically the short chain, 6 to 12 is the medium chain, 13 to 21 is the long chain, and then beyond that you get into the much longer chains. So that's important to note, because you'll hear this term like medium chain triglycerides a lot, and it's really referring to the length of that carbon chain. The second thing that's important to note is the double bond, as I've shown there. If there's no double bonds, we call that saturated. If there is a double bond, we call that unsaturated. And for us, because of the machinery we have to sort of deal with these lipids, it's also important to note where that first double bond is. So as an example, I don't know if you could see at the top, very top right-hand corner, there's a label called omega. And so that's the omega carbon. And then going away from that, if we go to the third carbon from the omega carbon, that's an omega-3 fatty acids. So many of you have heard about this in like fish oils, things like that. Omega-3 fatty acids have a lot of beneficial properties. If we keep going, then there's a 6th carbon, omega-6 fatty acids, and those have different properties. But soybean oil is almost 50% linoleic acid, and that's shown there. And that's one of our carbon-18 omega-6 fatty acids. And so just before I get to what that means, this is a really pivotal study, I think, and it's worth kind of going over. This study was finally published looking at replacing 1/3 of the calories provided from dextrose with lipids. So in this era, we again were not using lipid emulsions commonly. This study showed that by doing this, they were able to reduce the amount of dextrose that we're providing and really prevented a lot of complications that, to an endocrinologist myself, are very important. They lowered the blood glucose level because previously many of the patients were having very, very high glucose amounts. They were also showing that the triglyceride levels went up a little bit when we gave this ILE. And then also some of the liver numbers started to rise. So this is one of the earliest studies that kind of looked at replacing some of those dextrose calories with lipids and showing there's benefits, but there's also drawbacks. So just to summarize, soybean oil, lipid emulsions. Soybean oil is a good source of non-protein calories. It's an excellent source and probably one of the best that we have for essential fatty acids. Like I said, half of it is made up of linoleic acid, which is one of the big essential fatty acids. Using it also allows us to improve glycemic control. In that study, almost 15% of the patients had numbers that we would call diabetes today. So with TPN, without lipids, many were having issues. And then 2 of the patients were noted to have chronic pancreatitis. And this is important as I go into kind of our case. And so what my thought here was to use a patient, and the first patient that we used the new lipid emulsion on to kind of highlight what some of the issues that we are encountering with the use of lipids in patients. So this is a gentleman, 32-year-old, who's been on TPN for many years in the setting of intestinal dysmotility and pseudo-obstruction. And he was going along fine, and then in 2011 was diagnosed with AML, so that's a leukemia, and underwent stem cell transplant. What happened after this transplant is that his liver numbers started to rise once again. So we noticed this and did a full workup looking for any other causes. At this point, we didn't know if this was related to his transplant, his leukemia, or if it was related to TPN. He was completely dependent on TPN, so we were hoping that wasn't the case. But we ended up doing a liver biopsy, and when we did that, the pathologist read it as this is an effect of TPN. It's not due to any other cause. So this put us in a very precarious situation because he's completely reliant on TPN for all his calorie needs. But some of the issues that also started to come up with using the soybean oil ILEs is that, again, as I mentioned, they have a very high ratio of omega-6 fatty acids to omega-3 fatty acids. So that's shown here. Their ratio is 7 to 1 almost. And what that does, just kind of reviewing this, what that ends up doing, there's no way you can read that or look at, all those enzymes. But essentially, that right there are all the big machinery that we have to handle these fatty acids. So we have omega-3 fatty acids, omega-6, and omega-9. The machinery is the same. So that's how we handle them. And what ends up happening is that there's byproducts that are generated from this sort of breakdown of these fatty acids. And unfortunately, in the case of omega-6 fatty acids, as our machinery sort of breaks them down, it tends to generate byproducts that are then pro-inflammatory. And that's the struggle we've always had with these fatty acids. The omega-3, on the other hand, are less pro-inflammatory. And in fact, new research having the same issue. I'll just keep pressing. Or could we go to the next slide? I'll just keep talking then. But as we look at new research, what we're also seeing is that not only is it less pro-inflammatory in terms of the omega-3 fatty acids. Now we went too far. One back. Maybe I'll do it. There we go. We're also starting to see that there's a component of generating inflammation. So if we get sick or we get a serious infection, our body generates this inflammatory state. What happens in some cases, especially in patients who are in the ICU for a long time, unfortunately, this inflammatory state doesn't go up and then resolve. They instead start to go into this chronic inflammatory state, which can almost be worse. What we're looking a lot into this, and what we're seeing is that there are a number of molecules that help us resolve this state, and we call them resolvins, which is clever, I think. But omega-3 fatty acids play a large role in resolving this inflammation, which, especially for our critically ill patients, can have a big impact in kind of resolving their health. So that's what I've shown there. Other things, and this is research from Dr. Bistrian's lab at Mass Gen, they even looked at providing high amounts of soybean oil ILE and then looking at our immune system. And what they found is that it suppresses our immune system's ability to kind of handle infections as well. So there's a lot of these issues that we've known for a long time. And another issue is the high phytosterol content. And so what's phytosterol? Phytosterols are actually plant cholesterols. They're great if we consume them through food because they will block animal cholesterols from being absorbed. But if we're giving them intravenously, our body has difficulty handling them. And so that can also pose a risk as well. And you can see the sources of phytosterol, right? Soybean oil is quite up there, but safflower oil, corn, they have high phytosterol content. So again, this becomes an issue if we're giving it intravenously. So all of these things combined, at least in our outpatients, we believe multifactorial can cause liver issues in the long run. And so because of this, many of our guidelines and our organizations, especially looking at the inflammatory component, have recommended withholding soybean oil lipids in those who are critically ill. And in the outpatient setting, we're exploring other options, and I'll get to that. One of those options, at least in this patient, when liver issues start to arise, is to begin decreasing the amount that we give. In the US at least, I think due to Dr. Kelly's work, it's become quite common that we typically give lipid emulsions 3 days a week. So that's what he was on. He was getting 50 grams 3 days per week. We decreased that down to 50 grams every other week. But in order to compensate, because he started to lose weight right away, we had to increase the amount of dextrose, going to over 500 grams per day. And then you can see his liver numbers started to get better. But unfortunately, soon after that, he then presented with pancreatitis. And that's what's shown there. We did a full workup for all causes of pancreatitis, again, because TPN is his lifeline. We almost don't want to believe that he's having these issues because of it, but we couldn't find any other causes. And during one of his episodes, I happened to be on service, and we ended up checking an insulin and C-peptide level. Those are, insulin is made by the pancreas, and I've shown you the normal range there, and you can see he was almost 4 times normal. So the formula we were giving was causing diabetes in this gentleman, but we had to because we had to maintain his weight. So that was the consequence we've been having. So this is not uncommon, and because of this, we've been on a quest to look for ways to reduce the amount of omega-6 fatty acids or soybean oil that we've been using in our lipid emulsions. So this is not anything new. Worldwide, we've had a number of products that have been available. As you can see in the 80s, using those medium chain triglycerides, combining them with soybean oil. Other options have been combining olive oil with soybean oil. Then using 100% fish oil has also been an option. And now we're getting into the era of using all of the above, sort of combining the best of each. And there's products available. But again, targeting this ratio of trying to push us to the less inflammatory state has been the reason why we've been doing this. So one of the first ones, as I've kind of highlighted, we use medium chain triglycerides. The big thing with medium chain triglycerides is that they're small. And so when we consume them orally, they go right into our blood system. They don't have to go through the normal packaging that the longer chains have to. They go right to the liver and then can be used for energy. So people think that they're cleared more rapidly. This is why there's such I don't want to use the word, but I will, craze, I guess, for coconut oil and other products that contain high amounts of medium chain triglycerides. Again, we do have to mix this with the long chain, the soybean oil, because medium chains don't have essential fatty acids. So that's something we have to do. Another, and this product is available worldwide, is to combine soybean oil with olive oil. It's been approved in the US, but not really marketed. So again, we're hoping that it does get marketed because we need choices. But olive oil is also a good source for us to be able to reduce the amount of soybean that we're using. And then fish oil is another great source. This has probably the highest amounts of omega-3 fatty acids, which are, again, the least inflammatory. And as I've mentioned, the EPA and DHA also tend to help us resolve inflammation, which is key for many of our patients. So in this gentleman's case, we struggled for quite a bit on how to deal with this. First, we started reducing the amount of dextrose that he was getting, knowing that we had almost caused diabetes because we were giving him so much dextrose. But then his weight started to drop right away. Then we even asked the FDA to give us approval to use 100% fish oil, Iyer, on compassionate use. We even restarted enteral feeds at night. We were kind of just throwing everything at him to help him get through this and get his weight up. But what ended up happening is because of the formulation of fish oil, we had to use a separate pump. He was also actively working and so had to give all of his nutrition at night. So he was running 3 pumps, one for his TPN, one for that lipid emulsion, and one for the enteral feeds. And he just wasn't sleeping and was diagnosed with chronic fatigue and fibromyalgia. So with that didn't work as well. So then, luckily, we had bought enough time that finally the mixed oil Iyer became available in the U.S. And this oil, Iyer, uses a combination of soybean oil. So 30% is soybean oil, 30% is medium chain triglycerides, 25% is olive oil, and then 15% is fish oil. So by doing this, by combining all three, you could see there that omega-6 to omega-3 fatty acid ratio is reduced. They've also been able to reduce the phytosterol content as well. And there are trials that have come out looking at use of this in adult and pediatric patients, and so far they're showing it's safe and well tolerated, and they're also hinting at the same thing: improved liver numbers, improved vitamin E numbers, but the duration of those studies is short-term, 5 to 28 days. And I think all of us, are excited about having this option, and many of our guidelines are also reflecting that this could be an option to use in those patients, especially who are critically ill or need that less pro-inflammatory milieu. So that's what's shown there. For our patient, it has worked wonderfully. At this point, we weren't as experienced with its use. So what we started to do was we basically started at the same dose that they were getting of their last soybean oil lipid emulsion. So if someone was getting 50 grams every other week, we again would start the mixed oil Iyer at 50 grams every other week, check the liver numbers, and then continue to titrate up. And that's what we did with him. And we kept going and checking the liver numbers and got all the way to 70 grams, 7 days a week. So this is rare with the soybean oil. we were also able to initially go way down on the dextrose, but then started to come back up and give him extra calories. And then his weight finally increased all the way to 61 kilograms. So BMI was above 20. Previously, his BMI had gone all the way down to less than 18. So we were getting nervous. Since then, we've had about 30 patients that have also been transitioned over who had liver issues or were not tolerating the soybean oil for other reasons. 15 of them are now close to or well beyond 12 months of use, so really long-term use. And you can see there, when we average them out, it's about 380 days of use. Those are their indications, but to highlight what we've been able to achieve, and I'll show this in some graphs coming up, but we've been able to reduce the amount of dextrose that these people were getting from 65% of their calories down to 54. You can see when we can't use lipids the way we want to, we have to compensate with dextrose. And sometimes 70% of the calories or even more are from dextrose. Many dietitians in the audience probably cringing at that kind of a ratio, but that's what we were doing. The lipid amount, as you can see there, was all the way down to 10% of their calorie needs. And we'd like to see that go all the way up to 30%. So that's what we've seen, and the liver numbers are there, but I'll show that better in the graph. So this is what we've been able to achieve in these individuals. You can see the red is the dextrose amount, and that's going down. The blue at the bottom is the lipid amount of calories, and that's going up. And then in terms of the liver numbers, I've put that in a graph here. You can see that line that goes across, that's 0. So anything above that means that the liver numbers got worse, but anything below it means the liver numbers got better. So we've been able to go up on the lipids and not make things worse. That's been the big achievement that we've seen. In fact, many of the liver numbers have actually gotten better despite us going up. So with that, I think we're excited about this opportunity. We always love variety, you know, and we think there's certain patients that are going to benefit right away. One of the patients that we've explored are those that are intolerant to soybean oil. Those are patients that we've now transitioned over, and we have over 15 that have gone beyond a year on a mixed oil ILE. Again, we think they're also a good source of non-dextrose calories. More to come in terms of critically ill patients. We'll see what our guidelines say in the future, but could this be an option to use over soybean ILE in the first week because of that improved omega-3 fatty acid to omega-6 ratio? Again, lots of trials in adult and pediatric patients showing some trends towards improvement in liver function studies, improvement in our inflammatory markers as well, and then our home parenteral nutrition population. That's where we're the most interested, and this is where my disclosure is, in that we are looking to perform a long-term trial looking at the use of mixed oil ILE in our home parenteral nutrition population. You know, could it be an option over soybean oil? Again, trials in adults and pediatrics showing lower numbers in terms of liver function studies and lower triglyceride levels. But the big point is that the data is short-term. We really need more data, especially long-term variety, 3 months or beyond. So that's what we're looking for. So thank you.
Manpreet, this is a dream that I had about 15 years ago when I presented at the nutrition meeting in Florida. I was assigned the new lipids available in Europe. And I started my talk with, I hope there's nobody from FDA here, because it seemed like they were just sit on things. And it took us at least 10 years before it was finally available. And these are the types of patients that this is so critical for. So, You've done a really nice job of outlining that entire course. We still had some big questions, and occasionally my successor and maybe you were saying, why is this happening? But nice talk. It was great. Thank you. Oh, by the way, the FDA person came up and handed me her card at the end of my talk.
Any questions?
I think way back there.
Oops, way back there.
Hi. So you talked a lot about the alternative to soy-based lipids, but that's still got soy-based lipids inside of it, right? And I know from personal experience, some people just can't do very well with soy-based lipids. So what is the rate of acceptance for lipids that involve no soy whatsoever?
Yeah, I think when we look at literature, you know, the big issue that's always been identified with not using soy is that soybean is 50% linoleic acid and has a lot of alpha linoleic acid as well, which are our two essential fatty acids. But going back, if you look back to like 2005, Kathleen Gura actually presented a series, especially, you know, a series looking at just using 100% fish oil, and showed that patients actually didn't develop essential fatty acid deficiency. And what we think is that there is mechanism that can convert some of the byproducts to arachidonic acid and other things that prevent then essential fatty acid deficiency, almost calling it a conditional essential fatty acid, in that, you know, they're not developing symptoms with this. And since then, there's been a lot more research pointing at that. Sorry, I'll let you go, yeah.
I was just going to say, I've heard a lot of debate about the idea whether essential fatty acids are needed in TPN or not. I, for one, don't eat food. I've been on a Megavan for 3 years straight now, and I'm healthier than I've ever been.
No, that's what we're hearing, and I think for us, the big push, like Dr. Kelly was saying, is we need all of these available so that we can truly study them and define which patient fits which one. You know, and it's, yeah, we're also so jealous of Europe and worldwide, where they're like, what are you talking about? Yeah, 92 countries have multiple other options available, so yeah.
I'm following up on that question. I was wondering if you are tracking the omega-3 fatty acids, the EPA and the DHA in these patients, and how do you see it change over time?
That one's hard to do clinically, again, because, you know, we need funding to do these tests that insurance says aren't totally necessary. So in our trial, we do plan to do that. We'll have a whole panel that measures the fatty acid content, especially the essential fatty acids. But clinically, it's very hard to justify just checking those if, you know, we're not able to say it has this implication. Insurance just won't cover it. So yeah, that's been a struggle. And they're expensive to do, yeah.
I was wondering, I like my doctor a lot, and
Thanks for saying that.
and but I've been losing weight a little like a leaky balloon, and I'm wondering if adding a little more of the SMOF, which I'm on and seem to tolerate really well, if that would be an option for maybe helping me gain a little bit of weight back.
Yeah, no, absolutely. And I think, you know, for most of our patients, we also monitor labs very carefully and certainly try and increase as much as we can. But then sometimes things like high triglycerides or other issues come up that prevent us. But certainly, you know, we've explored that in many of our cases, going up and seeing how patients do. Yeah.
Thank you.
Right back here.
So what can we as consumers do to get the FDA to approve these things in faster ways? Because I'm a case where my liver enzymes were really bad, and when the SMOF came in, my doctor put me on it immediately, and they are within normal limits within 2 months, and they've been fine, and I've been doing, well, I thought I was doing good before, but I've not had any problems. So, but again, what can we do? Because we're the ones who are going to be the ones saying that we're the example. It's sort of like a company that creates clothes or something. They're not going to listen to the people that sell the clothes for changes. They're going to listen to the consumers who buy them. So what can we do?
I think advocacy, and this is one of the greatest things that I feel about Oley, is that we can gather these stories and just sharing exactly what you just did and sharing that with the FDA. Sharing to me how critical TPN is for many of our patients and consumers, in that that's their lifeline, that's nutrition, right? And how critical and how stuck we get if we're having high liver numbers, then we're seeing weight loss or high amounts of dextrose in the TPN. So sharing these stories, I think, will make the biggest impact of how big a group we have, and how important this is. Yeah, I don't know if you...
Write to your legislators personally. Write to your legislators personally, because if we carry the message to them, they may or may not listen to them. And actually, one of the people who just talked to you, the one who said you're a great doctor, she presented in the legislature many years ago, and they had the docs from all over the country speaking before her, and all the legislators were talking among themselves and not listening. And when Liz started talking, they listened. So they will listen to you better than they will listen to us.
My son is 5 years old and is on SMOF, and we are somewhat interested in increasing his SMOF to see if we can get greater weight gain. The concern is that if we see his liver enzymes start to elevate, could it be a situation where the damage is done and now they're going to continue to elevate, or can you then decrease SMOF and see those numbers go back down?
I think if we're following closely, sort of the inflammation and that permanence that we used to see leading to cirrhosis and needing, liver transplants, if we're following closely, you can catch it. So the liver numbers are very, very early markers that the liver's upset, it's inflamed. So in our experience, we'll have Kishore kind of answer. Oh no, I was like, great, I've got a transplant surgeon here. But yeah, we've been able to see, and in many of our patients, as you saw from that graph, they were having liver abnormalities for years. And then when we transitioned them, you saw that their numbers even got better. So it just depends on your team, though. There could be other reasons for not going up, like I mentioned, but you can talk to them and see if this is an option.
I just wanted to comment that this was a very good talk, but I will say that it's a mistake to presume that if your biochemical liver tests are normal, then it's a mistake to assume that the liver is normal. We have a paper published last year showing a very high incidence of histological liver injury, meaning on biopsy the liver is damaged when the biochemical tests don't suggest damage. I have a personal theory that we're now creating a generation of TPN patients whose liver tests will be normal because we've got interesting lipid emulsions coming down the pike, but that does not necessarily mean that the liver damage is not occurring. It's occurring in a more occult fashion. And Darlene, that leaves me with 1.5 minutes to spare.
Hi, Ann Mikulik from Albany. My question is, just as Kishore was saying, sometimes we have patients that have liver damage that we have had totally normal liver function tests for years. And now there's fibroscans. Is that a way to look at it? Kishore and I have discussed, is it something that we want to think about biopsying people intermittently, like what interval, who knows? How do we, what's the best way to monitor this to prevent the long-term liver damage that we don't see in the blood test?
That's the great point, and this is sort of, to me, the art of medicine, as opposed to the science, is that we haven't had an option before. Beyond the liver function studies, the tests are so expensive, in the sense the fibroscan can be thousands, so it's an MRI. Then the liver biopsy can have its own issues, and so because of it, we routinely haven't done this in patients. But now, do our guidelines think about adding some of these other variables to try and catch the occult liver issues, because we have other options.
You talk about expense, but what's the expense of cirrhosis? If a patient gets to the end stage and we didn't spend $1,000 10 years earlier to identify they had some fibrosis. Now it's a huge cost, not only in money, but in somebody's life,
And maybe, when do we do this? I think all of this needs to be defined. Someone who's been on TPN 3 years, 5 years, at that point, should they get one of these scans? I think all of this needs to be teased out, but it's an exciting time.
The fibroscans were studied with a group from Aspen, and it's been published that they're not very great for this purpose. There are MR studies that are specialized MR studies, but they're even more expensive. But as Ann says, how do you weigh the cost with life?
Yeah, that's been the struggle. The MR elastography, I think, has been an option that we've used.
So to be continued.
Yeah, thank you.
One right here.
Thank you very much, Dr. Mundi. Okay, because of the duck march that we're all familiar with, we're closing that door. If you need to get out, we'll let you, but use this door. And last but not least for this morning, we have echo intestinal failure with Dr. Kishore Iyer and Kelly Tappenden. Dr. Iyer is well known to Oley. He served 6 years on our board, and we asked him to leave. But we ask everyone to leave after 6 years. Oh, I forgot that part. But it was an exciting 6 years, very lively. He's learned about an echo project. He pulled us in. We went to the immersion course. It almost killed us, but we're here to talk about it. And I'm going to let him tell you, along with Dr. Tappenden, who is also an Oley board member. See, we get the best of the best, I'm telling you. So with no further introduction needed, Dr. Iyer.
Thank you. I'm very used to operating under pressure as I'm a transplant surgeon, but this is tough. Darlene Kelly tells me 0 minutes before I start, and I am going to ignore her. So if I studiously stay away, not look at this table, that's one. Kelly Tappenden, my friend and good colleague, just pointed out we are competing with the Ducks, but we'll do our best. I almost didn't come because it's so difficult to get to Memphis. I was on the last flight, it kept getting delayed, And then they said, we're looking for 6 volunteers because of weight concerns. I looked at myself and I thought, oh no, please. Then they said, we're going to pay $500. And so then they announced, we're now looking for 4 volunteers and we're going to pay $750, and the flight's delayed now. And I'm thinking, oh, please, somebody take the $750, let's go. And then they said, we're looking for 2 more volunteers to come off this flight, and we're paying $1,000. I said, let me pay some attention here. And then it came to $1,500 for the night, and I was going to call Joan. Joan, will you please wing it? I'm not coming. So I had to actually make a value calculation whether it was worth coming. I'm here. You can make whatever conclusion you want. This is my idea of a cheap date. Okay. This is an interesting new idea. Interesting means many things to many people. We are very excited by it. Some of the people who've joined this effort, perhaps a little reluctantly, but I hope you'll agree that there's some room for excitement. Let me see if I can make this work. I don't know where I have to point. There are my disclosures. Other than the last one, none is relevant to this talk. And perhaps you can help me at the back. If you can click the hyperlink, I don't know if I can do it since I don't have a keyboard. I'm going to let the people who came up with this idea explain it. We'll watch a movie on Netflix next.
I'm a specialist in liver disease. I used to run a dedicated hepatitis C treatment clinic in the university. Some patients would travel 200, 250 miles each way to Albuquerque to see me.
He's getting his diuretic therapy, he's getting the...
I found it extraordinarily frustrating that some of these rural patients would come to me at too late a stage. I always had that nagging thought that if I had just been able to treat them earlier, I would have been able to prevent this problem.
That looks like New York.
If you're in a remote area, the specialists that I need and that Ashley needs, we don't have those specialists. We'd be traveling once a month out of town, quite a ways.
Squeeze nice and hard for me. As a rural physician, I'm not exposed to the constant didactics and grand rounds and M&Ms that a physician in an educational institution is getting.
So we came up with this echo model with the idea that if I could get rural clinicians who would be willing to be mentored by me, then permanent addition of capacity will occur in these rural areas. We use technology like video conferencing.
Recommending end of treatment value load and 6-month post.
We started with hepatitis C, and then we realized that patients with substance abuse disorders were not getting good health care in rural New Mexico because there were no experts in that area. We had experts in Albuquerque, so we said we would echo them. One thing led to another. After that, we started a diabetes program. Now we have echo projects in 19 separate areas. Every day we have a different echo project going on.
She's a physician assistant, and she's actually also interested in the pain echo.
The primary purpose in Project Echo is not to treat individual patients. The primary purpose is to build expertise.
Go ahead, Angela.
Thank you, Dr. Baker. Patient LO is a 39-year-old patient.
Over the last 20 years, I recognized what are we going to do with this massive number of people that have to be seen by us. And fortunately, through the ECHO program, I can finally access these people.
So why don't you just hold the hydrochlorothiazide? Okay. Let's stay on everything. A local ophthalmologist started sending me a whole bunch of patients with possible Sjogren's syndrome. And I'm sitting there on the computer going, okay, I know what Sjogren's is, but how do you work it up and what do you do? And it just sort of started from there. But I did do a full autoimmune workup on her, which was all negative, including during the sessions I'm able to make suggestions and ask questions or clarifications, even if it's not my own case. It's a giant mind center of collaboration.
She has some pretty significant contractures in her right hand.
Video interface allows us to build what we call a community of practice. That is, there is collegiality, the same as you experience when you're doing rounds in a hospital.
Dr. Bankus, would you consider compression stockings, thinking that this could be an element of post-lipidic syndrome?
Well stated, Madhu. What do you think, Naomi?
Oh, she doesn't have edema per se, but
It is best practices all over the state to these sites. And mind you, these providers are really talking like they're rheumatologists. They know all the lingo, they know all the therapies, and it's very gratifying.
The primary idea in Project Echo is something which we call a force multiplier. For every one patient that's presented, many more patients benefit because the expertise of the clinician increases, and this enhances quality of care.
how are the knees doing?
Knees are good.
Are good. Okay, good. The more I know about rheumatology, the more I recognize it in the clinical setting, and the more people I'm diagnosing. This also opened up an entirely new field to me. You know, I'm now getting referrals from other physicians at the hospital.
We started Project Echo in New Mexico just for rural areas and prisons. But then our urban sites wanted to join us. And so we said, yes, do it. University of Chicago has Project Echo going on for treating hypertension in African Americans. In the University of Washington, they now have 20 sites. The care that these doctors provide is as good as we provide in the university. It's as safe and it's as effective. We've been able to demonstrate conclusively that the model works.
Let me just make sure that I'm at the right, what happened here? Okay. So over the last few months, I've had the opportunity now to talk to Dr. Sanjeev Arora many times. And as Joan mentioned, we took a team to Albuquerque to do an immersion implementation workshop over 3 days. And I will say, irrespective of where our project goes, Dr. Arora himself is just one of the, maybe one of the cleverest people I've met in medicine in many years. And also one of the most selfless and generous in terms of sharing his expertise and knowledge. So the idea of ECHO, as you heard there, ECHO stands for Expanding Community Healthcare Outcomes. And the idea is to use technology, remote conferencing technology, there's some specific software, use technology to leverage scarce resources, to share best practices to reduce disparities in healthcare outcomes and quality of care, to apply case-based learning to master complexity, and then as a team undertaking this project to evaluate and monitor outcomes. And the third point there I want to emphasize, one of the things that I heard repeatedly from Sanjeev was, how does one become a specialist in medicine? You start at a general level, you finish medicine, you could be a primary care doctor, but then you do a residency or a fellowship to become a specialist, and that's how we become specialists. Now, surgical specialties are different, it's a bit more of an apprenticeship because there's a technical aspect, but how does Dr. Mundi become an endocrinologist? You present cases, you hear some lectures, you get feedback, voila, 2 years later, you're a world expert. And that was, that was at least Dr. Arora's aha moment. And having met him, I suspect he has many of them. But there are now 65 or 69 different ECHO projects around the world. And he has and states very modestly a goal of impacting 25 billion lives by 2020. And I will say that I think it's not an unrealistic goal. So intestinal, how do we apply this for intestinal failure? Here's what we're thinking of doing. And it's a pretty ambitious project in terms of scope, in terms of timeline. But those of you who know me know that transplant surgeons are not put off by minor obstacles, so we're going to do this. witness how I dealt with Darlene. So we're planning to launch a pilot project in January of 2019. Just by necessity, there needs to be an infrastructure somewhere. So the ECHO host institution will be at Mount Sinai Hospital in New York, the Icahn School of Medicine. And our intent is initially to launch it sort of in a pilot fashion, even if we're not calling it that, in the northeastern part of the country. We've drawn a boundary around, from the top of my head, at 9 or 10 states with a target population of about 70 million people. I did that on the basis that knowing intestinal failure prevalence data, conservatively, we probably have access to about 400 patients with intestinal failure in the region, give or take. The truth is we don't even know that. And our intent is to upscale nationally very rapidly, because one of the challenges some of you may have already thought of is the fact that hepatitis C or diabetes are very common diseases versus intestinal failure, which is a rare disease. So to some extent, this will sound funny, global domination is going to be the answer to making this successful. The more patients, the more clinicians who come into this project, I think the more likely this is to succeed. We've constituted an advisory board already, and it started with the people who agreed to drink some Kool-Aid that I offered, and now hopefully we're drinking the Kool-Aid. There may be more available to anybody interested, but you can see the participants there. We've got some technical support from Sinai, and we've got some other support that is still being negotiated, but we're going to get this project off the ground. From those of you who don't know her, there should be very few. Dr. Tappenden has a lot of expertise in this area, has been a past president of Aspen, and is editor-in-chief of our, I'm going to ignore that bell, I hope it's not for me. And we have Marianne Winkler, also a past president of Aspen, very active, both at Aspen and at Oley, from Mayo Clinic in Scottsdale. John DeBase, who might be familiar to some of you, gastroenterologist interested in intestinal failure. We've been able to persuade the American Society of Parenteral Enteral Nutrition to join this effort. So they're going to, hopefully, we will know in the next month or two, take care of all the continuing education credits that we'll provide to remote physicians, clinicians, as part of this effort, as part of patient advocacy, and to try and get an idea of what the consumers really want. Joan, Lisa, and Betty Bond, I see Betty there, from Oley, and then a couple others, because we want this to be national. We want to understand what the challenges are. Some of you may know Optum Healthcare, indirectly responsible for coverage of about 45 million lives in the US. Their National Medical Director for Transplant and Complex Conditions has joined the advisory board, and Ron Potts, who is CMO for Interlink, a healthcare reinsurer, and he's chief of transplant quality for Kaiser, has just joined the project. So we have a multidisciplinary advisory board to help us flesh this project out, and it also represents the sort of multidisciplinary expertise that we think intestinal failure care needs. What you will see there, not yet identified, applications now welcome, where it'll be looking for a pharmacist interested in nutrition. We may be looking for a psychologist, and we may be looking for other people. We may, we intend to have movie credits at the end of this, and so there may be. I've always wanted to figure out what a best boy grip was, and I don't know. So we'll have all those. Our project plan, and I'm on the home straight now. Our project plan, at least as we've conceived it right now, we plan to do 2 tele-echo clinics for intestinal failure per month. Each clinic will last about 90 minutes. The intent will be to discuss 2 cases per clinic. These cases will be submitted beforehand to the clinic coordinator. They'll be presented to a standard template. We're thinking about 15 to 30 minutes of presentation, maybe 15 to 20 minutes. I don't know how I'm doing the math, but you get the idea. 15 or 20 minutes of presentation, 15 or 20 minutes of discussion, and then there will be a short didactic presentation at the end of each clinic. There might be a 15-minute lecture on best practices to prevent catheter-related infections. There might be a 15-minute lecture on tube feed complications or on blenderizing. I learned something this morning. And our intent is to develop a library, a continuing education library that will support clinicians who participate. And of course, the incentive additionally is that we will provide free continuing education credits for participants. We can discuss this some more, but the last line is important for a variety of reasons. These echo clinics are not directly open to patients. Why am I still preaching to you and hoping you will support this effort is so that you will go back to your clinicians and say, would you care to participate and present my case if things are not going well, or even if they're going well. The idea is essentially all teach, all learn. Our strategy, here's the first problem. Now you know why I was tempted by the $1,500. We have no money. So we have some soft funds to get this project off the ground, but we're exploring extramural funding. We will be looking for unrestricted educational grants, but frankly, this is very low on our list of anxieties right now. As I said, we intend to start ECHO IF in January 2019. What I am here in part for is to try and recruit participating spokes. And that's the first time I'm using the term. Think of it as a virtual hub that provides a multidisciplinary team of experts with spokes who are looking after patients with intestinal failure, who think things are going well, but maybe want to ask about what should I do with these rising liver tests, or what should I do with these 2 fungal infections my patients had? Can I start weaning TPN? Should I use this new drug, etc.? And we're looking for 2 types of spokes, we think, and we're open to ideas, but we're looking for clinicians at home care companies, because the reality is well-intentioned clinicians with a range of expertise are doing the best they can to look after complicated patients, often with very little medical or clinical help. And we're also looking for non-specialist physicians at medium-sized hospitals who should and could be looking after intestinal failure patients well and are struggling right now. As part of our effort to call this a project and to ensure that we continue to fund and we do this in a responsible fashion, we will be measuring the participation, we'll be measuring value to participants, we'll be measuring patient-reported quality of life. What happens for patients whose clinicians are participating in ECHO perhaps, and they don't have to go to a Boston or a Los Angeles or a New York every month to get their care? Is their care as good as it would have been if they'd been under specialist care? And is their quality of life hopefully better? We're also going to look at some objective measures in an exploratory fashion to see if we can quantify the benefit. I think that's my last slide. So we've believed for a long time, and that's subject for a different topic perhaps, a multidisciplinary approach to intestinal failure management appears to achieve improved outcomes. We think that the ECHO model is an exciting and disruptive medical innovation. We think it has the potential to produce a paradigm shift in intestinal failure management. This will provide, the goal in the context of intestinal failure will be to provide a virtual multidisciplinary consult service staffed by experts. May lead to improved outcomes in intestinal failure care, we think. And as I've said now a few times, I'm on the record, this is being recorded, we plan to launch in January 2019. I'm going to stop there. We really want criticism directed at Dr. Tappenden. No, I'm kidding. We really want, Kelly, if you don't mind coming over, we want criticism, we want feedback. This is your opportunity to join the sort of design phase of this project. We want questions, we want to hear about things we've not thought of, and we want, hopefully, enthusiasm. Kelly, you want to add something?
Sure. You know, what I think we would find really useful in trying to initiate and create this project the best way that we can is hear from all of you. Now, what you were told, of course, is that the primary purpose of ECHO is not to treat individual patients, but to create experts in the field, right? So we're asking many of you as individual patients, is this something that would be of value? To you as individual patients, some of the things that are obvious to me would be that it could reduce travel for those of you who are traveling a long way to see your team. It would give you access to experts. For those of you who don't have someone who is an expert in this area, they could receive consultation, of course. And you would also get interdisciplinary feedback, where in many places you won't have access to an interdisciplinary team, which has been shown, of course, to increase the quality of care that would provide to you. Some of the concerns, what might some of you have for concerns about that? It may be that you want to travel to go and see your team that you have a long history with, right? Tell us the benefits and the issues that you see so we can develop this most carefully.
The benefit for us, the benefit is that our son has a rare condition where every specialist that we've seen, he's one or maybe the second child that they've seen with this condition. And so it would be amazing for our doctor to be able to connect with the other doctors throughout the country that have had maybe only one other patient with this condition, but together that makes a larger sample size. And so that's very exciting for us. I have one question for you though. Are you looking to divide it into adult and pediatric?
You know, we didn't mention pediatrics initially. That's our hope too. That was the goal of driving this project. We've gone back and forth a little bit. It's not written in stone, I'll say. We're still having twice monthly planning meetings. We've decided to start it with adult patients for two reasons, just to keep it a little more homogeneous. I do both pediatrics and adults almost equally. I have a sense that pediatric intestinal failure care is better. But our hope is that if we can iron out our teething troubles in the pilot phase, establish adult echo, this could be extended to pediatrics. Kelly, you want to add?
I think that's really, really important. That would certainly be one of my objectives.
And then one last question for me is very specifically, how do we tell our physicians to get involved in this?
We don't know that yet. Watch the tea leaves, read the paper. No. That's a great question. It's a great question. There will be more. I knew nothing about echo. This is what happens when a transplant surgeon gets 2 days off over Christmas. That's what happened. I learned about echo, and here we are, but we're going to flesh that out. There'll be flyers, there'll be through Oley perhaps, and outside there'll be mailers to physicians we're targeting, and it's a 9 or 10 state region we're starting with, but even that's not written in stone. It could be, if somebody's interested, we could open it up.
It's an excellent question, because in speaking to all of you, we're really speaking to the informed, right? And the greatest benefit will be to those that don't even know they have intestinal failure, and their physician doesn't even realize that. And how we access that group is something that we really need to try and figure out.
Can I ask you a question, if you don't mind?
Sure.
What would you think about an idea that Oley, or we through Oley, if Oley agrees, have a one-page flyer that you take to your physician?
That would be wonderful. Yeah. Absolutely.
Okay.
And I have a question about inclusion as well. I have 2 patients who I've been corresponding with for more than 2 years, located overseas, and they feel that their physicians are isolated, not up on the latest, and say, why do I have to learn something on Facebook and then go tell my doctor, and then my doctor has to Google it or go on Up to Date or try to figure out something? Would you be open, even though you thought 9 states to start with, including physicians globally, since we have the technology to make them part of a teleconference?
It's a fantastic question, and I will tell you to some extent my own personal incentive to try and develop this came in part because of that. At any given time right now, I think I have about 5 or 6 patients I follow pro bono overseas in parts of the world where there is no care. I've gone to El Salvador, operated 3 times, but the frustration there is you're helping an individual patient. You know, this is the cliche about giving a man a fish versus teaching somebody how to fish. So yes is the short answer. The longer answer is probably not in the opening phase, but we should talk some more. We're open to it, I think.
Okay.
Time zones may be the only constraint.
Yes, and
but really, Kelly doesn't need to sleep very much.
one of my patients is in a developed country, and yet, and yet, it's interesting because different health, you know, as the doctor from the Mayo Clinic pointed out, that German physicians were adding oil before it was approved in the U.S. There are, we may learn something also by including a physician from another country as well.
Sure.
Yes, one of the things that I see as a benefit with this program from a consumer standpoint is I've moved to an area where my original team is actually here in Memphis, but I'm now on the East Coast. And the people that I'm working with in the medical community there don't really know what to do with me. They still think that repairing a Hickman catheter is, no, we just replace them. And so I'm having those kinds of issues, so that from a consumer standpoint, there are times when I want a second opinion because, or I want to direct them to information so that they can help my situation. But I also want them educated. I don't want to be always pawned off on to someone else. So I see what you're trying to accomplish as being extraordinarily beneficial to us within our little tiny communities that we live in.
Thank you.
I saw on your slide that it said non-specialist. All specialists are not created the same. Is there a reason why you're not including specialists?
I'll take a shot and then Kelly go. You know, I was also, we've actually had some fun discussions about choice of words. Am I an expert? What if you disagree with me? I could, by the time we're all done, I could be in therapy. if somebody says, wait a second, how come you're a self-styled expert? I'm more of an expert than you. It's a great question. It's so in fact, we even, and I don't know that we're agreed on it, about calling it a hub and a spoke. That suggests a hierarchy, and the intent is to make it relatively democratic.
More of a network.
We don't, maybe we should talk about democracies the way politics is going right now, but let's stay out of the politics. But you know, to make it a little more, everybody's benefiting from everybody. Kelly, do you have a thought?
Yeah, we're trying to build this group of specialists, but to your point, we would not prevent someone who wanted to bring a case to the group from participating if they were a specialist. In fact, I think you could argue that the best specialist would want to seek the advice of others in the field.
But the flip side of that, though, and that we have to guard against a little bit, is not to have a dozen specialists who might have philosophical or stylistic differences, but are still doing a good job for their patients, just talk to each other and at the end of each clinic say, look how wonderful we are. Right? That's not the idea.
Our goal is to extend knowledge to those that don't have it.
Lynn?
Previously avoided getting into the payment mechanism.
Yeah.
And if you ask a lot of people who might be good physicians for a home TPN patient, they actually will, if you ask them quietly, say, I don't have time to take care of that kind of patient. They're much more time consuming. And so finding this doctor who's willing to do it. As you know, home TPN started where the only serious amount of money went to the pharmacies. Very little came to the attending physician. So the fact that he was not getting a specialist fee and he was extending himself incredibly in terms of time put more and more people on notice to avoid these kind of patients. That's the honest truth. So if you are going to start something which in a way is miraculous, which is to provide extended care for this kind of somewhat left behind patient, you've got to have, and even probably should talk about how you see this financially.
Lynn, you probably know this field better than most, and you and I have certainly talked about this, but it's not a coincidence that I decided to invite two representatives from a couple of the largest healthcare payers in the country. That's number one. Number two, having talked to Dr. Arora about this specific issue, the fact is every one of the ECHO projects that's being run now all over the world is being run on grant funding. So the original ECHO Institute in New Mexico has generated over $100 million in research funding. Other ECHO projects outside of New Mexico, a variety of them have generated similarly about $150 million in grant funding. And our intent, right now, all we are contributing is and that's not trivial. I will tell you, if you're in an academic institution, you know it's not trivial, but we're all contributing our time and effort and energy, I hope. And Sinai has been a little generous with me and are going to support us getting this started. But our intent is to get grant funding. Whether that can be leveraged 5 years down the road into some formal payment mechanism from government or third-party payers is a question I don't know. I suspect, given the amount of experience Sanjeev has and has not been able to do it, I suspect that's a big battle. But the other non-payment issue of what you asked is, the reality is there are many well-intentioned clinicians, some with expertise or some with pockets of expertise, who by necessity are looking after these patients with little to no help today. And when I was young and naive, as opposed to old and naive, I used to be a little cynical. But the fact is, many of the clinicians in home care companies are doing the best they can, often with a physician who might just sign off a prescription. This is a mechanism to provide those clinicians. It's a mechanism to provide a community gastroenterologist or a colorectal surgeon some additional expert support. It's not to try and persuade new physicians to say, oh, look at this wonderful patient population waiting to be looked after by you.
The one thing that I've been wondering when I've heard about this project, I think the idea is good, but all of the examples they gave were relatively common disease states. How have they had any that are more rare disease states like intestinal failure is?
So they are, the ECHO Institute and Sanjeev, they're quite excited that we're trying to start this project. They're telling us they're excited. I don't know if they're sitting in a room laughing and saying, look at these fools. No, I don't think so. They are, I think they're excited. But you're right, that is maybe our biggest challenge. In one of their sort of documents, they have 6 conditions that a disease state should ideally fulfill to be amenable to ECHO, and we fulfill 5 of them, and the 6th that we don't meet is it should be a common disease. The rarest diseases that there are echo clinics for right now that I've looked at, there is for sickle cell disease, which is relatively uncommon, cystic fibrosis. But here's the interesting idea, that they're now using echo for things beyond healthcare. They're using it for public education. They're using it for, when we were there, there was a team from whatever, US SEAL Team 9 or something, disaster management, right? So the idea is the same, don't move people, move knowledge is the idea. But time will tell, which is part of the reason why we think we need to be ready to upscale very quickly nationally. However that looks, it may not be the same group of people looking after it. May be that perhaps a group in Nebraska has to start a Midwestern echo for intestinal failure. We don't know that yet. We'll know in the first year or so, I think. Kelly?
Yeah, that is the big limitation, as you've just heard and perceived yourself. You know, I have to say I'm a little concerned about us starting in a geographical area, and Kishore knows this, because of the rare disease aspect of it. I'm hearing give a flyer to your physician, and we can then prioritize those individuals that are coming from us, whether they be out of the international or not. And maybe that would be a way we can get around it. Typically they're regional, but maybe we shouldn't be, in order to increase the pool of patients and physicians that we're.
Definitely our sort of northeastern start is not written in stone for certain. We're still discussing this. Oh, forget the yellow wall. We're chatting between friends. No, I'm kidding. Please show.
One of the reasons that it is being set up that way is there needs to be some infrastructure at the site so they can do the webinar aspect of it. But if that were in place, then we could go beyond that.
And the Northeast, we know referring physicians, we know patient sort of referring areas. Okay, we'll stop there. Can I just say one last line? Open to offline discussions and questions offline. Find us.
Right,
Thank
at
you.
lunch. Thank you very much. It's a record. Honestly, another round of applause for Kishore. Now we're moving on to hot topics in research. We offer, with support from NutriShare, we offer prizes to the 3 top research projects that benefit the HPN community. Andrea, please join me. Dr. Kelly, please. And Dr. Kelly, you have 2 minutes. How do you like that? Whoops. Introduce. Very good. Thank you.
So this brings us to the hot topics and research portion of the main session. NutriShare Home PN Research Prize, sponsored by NutriShare, was established in 2007 to encourage clinical studies focused on improving the quality of life of home PN consumers. Each year, the Oley Foundation awards $2,500 for each of the top 3 clinical research papers that are best aligned with Oley's mission. Clinical research is awarded points for each of the following criteria: how much interest the research would generate, and how well it fits with Oley's mission to enhance the lives of those patients. We'd like to thank our voting committee, which consists of consumers and clinicians, including Emma Tillman, a pediatric clinical pharmacy specialist at Riley Hospital for Children, Indiana University Health, and an HPN consumer, Jerry Mayer, an HPN consumer, Dr. Charlene Comfer, Associate Professor and Faculty Director at University of Pennsylvania, Dr. Lynn Howard, Medical Director and co-founder of the Oley Foundation, Dr. David Mercer, Professor of Surgery Transplant, University of Nebraska Medical Center, and NutriShare Incorporated. So thank you again to NutriShare for your continued support. We are proud to bring 2 presentations to you today, and I will turn the presentation over to Dr. Darlene Kelly.
Yeah, I know. I'm told I have 2 minutes. It won't take me that long. I just have to straighten out these things so that I introduce the right person as planned. You know, I don't have the information from, this is Marianne. This is not her address. Okay, I found it. No, I found it. It turns out that there's a little confusion on what's on this printout. Marianne Opilla, where's Marianne? Ah, good. Marianne is a nurse? Yeah, that's what it, see, I don't have the right stuff, but anyway. And she works with NutriShare. And her title of her project was Central Venous Catheters for Home Parenteral Nutrition, Characteristics and Outcomes of Devices in Place for 5 years or greater. So Marianne,
Thank you.
congratulations.
Thank you.
So.
I'd like to thank the Oley Committee for choosing my research. It's such an honor to be able to present this paper today to this group. Do I?
Pardon me?
Oh.
Got it to go?
I'm presenting central venous catheters for home parenteral nutrition, characteristics and outcomes of devices in place for 5 years or more. And Rodney Okamoto and Reed Nishikawa also contributed to this paper. Missing a slide. This was presented at the Aspen Nutrition and Science Conference in January of 2018 in Las Vegas, Nevada. Intestinal failure patients may require parenteral nutrition for years to a lifetime, and it's administered through a central venous catheter. So a very important outcome for these patients and catheters is to extend the dwell time for as long as possible without complications that eventually lead to removal. The CVC is considered a lifeline. I think I have the wrong slides. I think you don't. That's okay, we'll go ahead. What? It's in my bag. The information's here, it's just. Stop here and go with Yannick. Do you want to? Well.
You need help advancing the slide?
I need to go back one.
She needs to go back.
It won't.
Reverse it one.
All right. Okay, I can tell you. The aim of the study was to look at a group of home parenteral nutrition patients and identify the, oh, this is a great start. Hello. What?
Why don't we switch order and we'll just go ahead? Yeah.
And I'll give him my flash.
Good. Yeah.
Okay.
So let's.
Sorry, I'll be back.
We're flexible.
We'd rather have you have your slide.
You're set?
Oh, I am.
Okay.
Wait, is this the right slide?
Yes, I think so. Yes, there we go. Okay. All right. And we did this one. Okay. And the aim of the study was to examine a group of home parenteral nutrition patients and report the characteristics and outcomes of CVCs in place for 5 years or greater. It was done by a retrospective chart review from one home infusion specialty PN pharmacy, and it included adult and pediatric patients with a CVC in place for 5 years or greater. The data collection included demographics, CVC characteristics, PN regimens, care routines, and the reasons for the eventual CVC removal. We had 61 patients in the group that had one CVC lasting 5 years or greater. The age range was 13 to 91 years old, with a mean of 52 years. 62% were female. The primary diagnosis was short bowel syndrome, all causes, at 70.5%. And then we had 7 patients with intestinal obstructions, all causes, and 1 patient with radiation enteritis. We totaled the years of HPN for the group. It was 1,495, and this was a range of people on TPN for 7 to 41 years with a mean of 24.5 years. So a very long-term home parenteral nutrition population for sure. We totaled all the CVC days for all the catheters, and we looked at 241,219 days, which is about a range of 5 years to up to 21 years of catheter dwell time. The mean days were 10 years of catheter dwell time. So again, very long-term population. Most of the catheters were tunneled, 83%, and of those tunneled type catheters, they lasted a range of 5 to 21 years. We had 7 implanted ports, which lasted a range of 5 to 10 years, and 1 peripherally inserted central catheter, or PIC, which at completion of the data collection period was in place for 7.5 years. Most of them were single lumen at 95%. We had 5% double lumen and no triple lumen. When we looked at catheter material, 87% were silicone, 2 polyurethane catheters, and 6 catheters were not well documented as to exactly what catheter material they were made of. And then we looked at PN regimens because we wanted to see if there was a difference in dwell time related to how much infusion there was. And we saw days per week range from 2 to 7 days with a mean of about 6 days. And they infused 800 mils to up to 5,500 mils per infusion day, but the mean was about 2 liters. Cycle times range from 6 hours to 24 hours with a mean of about 11 hours. And 85% infused lipid at least 1 day per week. We also looked at various care routines, and these first 3 I like to consider are kind of infection prevention routines. And I was surprised to see that 34%, or about 1/3 of the group, used an antimicrobial site patch. And the reason that surprised me, because most of the research for these patches are on short-term catheters or PICs. They're not really indicated for long-term catheters, but the patients chose to use them in a long-term, for their long-term catheters. 18 of the folks placed it around their exit site for a tunnel catheter. 2 put the patch around their implanted port needle, and the 1 patient with a PIC used it also. Then we looked at the protective alcohol caps, which go on your end adapter when you're not infusing to help keep the end adapter clean, and we had 18% of the patients use those. And then we didn't have very many on alcohol lock therapy, only 4% used that, and they used it in a variety of ways. 5 of them used it 70% once a week, and 1 used 70% when they felt like it, and then 1 person used 30% daily. We looked at dressing types. The most popular dressing was transparent, all brands, all types, at 75%. We had almost 20% of the patients used gauze and tape, and then 1 person used a Band-Aid over their site, 1 person a Steri-Strip, and 1 person didn't use a dressing at all. We looked at primary caregiver because in past studies we have seen that people who take care of themselves tend to have a lower infection rate. And in this group, we also found that 85% did self-care. They did not have a person who took care of their catheter. They did their dressing changes and hookups on their own. 10% had a consistent RN, which is hard to find. Any of you that have nursing, you know you get a different nurse a lot of the times, but these people had consistent RN every week. And then 5% had a parent or spouse as their primary caregiver. We also looked at lab draw method again because we have looked at that in the past. And this group was fairly evenly divided. 59% had peripheral lab draws, and 41% had lab draws from the CVC. And that included self-lab draws, About half of them drew their own labs, and then the other half had a nurse draw them in a clinic setting or in the home setting. And the most frequent lab draw schedule was monthly, so a lot of these people only had labs once or twice a year, actually. So at the end of the data collection, 20 of the CVCs were still in place, and 20 were removed because of central line-associated bloodstream infection, which is not surprising. That's the most commonly reported complication for catheter removal. But the rate was very low, 0.08 per 1,000 catheter days. 8 of the patients had material or physical damage, such as holes, cracks, broken clamps. 8 of the patients had site failure, and this included exit site infection, thinning of the skin over the ports, tunnel infection also. 2 patients expired with the catheter in place. 2 patients, we don't know why it was removed. Only 1 patient had the catheter removed because of thrombosis, and none because of occlusion, which also was, I thought, a surprising finding. So in conclusion, the study findings are limited by the small sample size, but in this cohort of HPM patients, there was a subset who were able to maintain a complication-free CVC for 5 years or greater. CLABSI was the main reason for eventual removal, and very few consumers actually used infection prevention measures. Use of transparent dressing and self-care may impact CVC life, but more studies would be needed to actually confirm this finding. Material damage and site breakdown may be attributed to just wear and tear of the catheter over time. Constant handling of silicone can thin it, and that may be why the material damage that we saw. Infusion regimens, lab draw routines, thrombosis, and occlusion did not appear to influence dwell times. And this is my own conclusion, but I think that when it all comes down to it, the many, many years of lived experience, the education that people get over time, the knowledge that they get about CVC care probably contributes greatly to the low incidence of complications. And again, we see, as we've seen before, that the tried and true single lumen silicone tunneled CVC demonstrates the longest dwell time, and I think that this is probably the preferred device for home parenteral nutrition patients. And that's it. Thank you for reloading the slides.
We'll do questions. Now you can have the money.
I do have one question, and that is, of these 61, how many were pediatric patients?
I'm not sure. There was probably about 5.
Okay.
Yeah.
And
And
I
there-
would have to break it.
Oh, yeah, we are having a research breakout session at 4 today for anyone who wants to ask myself and the other presenters about the research.
Now, does anyone else have a question? Yes, a quick one. Now, she's the one that's pushing it in the time.
I know, I'm the type.
All right, well, thank you,
Okay,
Marianne.
Thank you so much.
Our next award winner is someone who I've seen a few times, notably once was last year. He was also an award winner. His name is Yannick. I only know him as Yannick, okay. Is it Wouters or Wouters? With a V, but it's spelled with a W. That's how some of those Europeans are, you know. At any rate, he's actually a colleague of one of the people that I know very well, who's been on the home artificial nutrition work group for years. And I guess he's his senior mentor, so Geert Wanton. His title is Repair of Damaged Central Venous Catheters is Safe and Substantially Prolongs Catheter Survival in Patients on Home Parenteral Nutrition. So come on up for your award. He's hard to miss in a crowd. So Yannick, congratulations.
Thank you very much. thanks everybody. All right, it's on. Well, I'd like to thank everybody for welcoming me here, a second year already, and for to be here and to present my study here at the Oley Conference. My study is, as you can see, about repairs of damaged central venous catheters. And just before I want to start, I was wondering myself, who has ever experienced here in the room damaged or broken catheter? Can you show me your hands? So that's quite a lot. And who's ever experienced also a repair of their catheter? So that's also a lot, that's great. Well, we looked at the repair of damaged catheters and more specifically the efficacy of it and also the safety. I hope, yeah. And this study was sponsored by Isley Pharma. As you may all know, home parenteral nutrition has remained the mainstay for the support of patients with chronic intestinal failure already since the late 1960s. And there are of course a lot of threats to the catheter lives, such as blood sepsis or occlusions of veins or catheters that may impact catheter life and also, of course, the continuity of home parenteral nutrition treatment. There's also another threat, and that is the damage of catheters. And that's why I focus on this. Well, damage to catheters, how often does this occur? Around 1 damage per catheter per 10 years per patient. That's a bit of an estimated guess. And there are several reasons for damage of catheters, such as the natural wear of material, which was previously said in the last presentation. Also ruptures due to flushing of occluded catheters. Sharp objects, such as knives or scissors that may cut the catheter. Repeated clamping maneuvers. You can see this here. Oh, I don't think I have a pointer. Oh, here, perhaps. Here. You can see here the clamping sleeve of the catheter. And the if you clamp it a lot, it may get damaged here on the catheter. You have also the possibility, a reason for damage is frequently bending. You see that often here. There's a more rigid part of the catheter and a more flexible part over here. And in between, the junction between those two parts, that is more prone to damage. So why would we repair damaged catheters? Well, broken catheters may eventually result in complications. Of course, if you have a hole in your catheter, it may leak parenteral nutrition or fluids. Perhaps that's not the worst case, but there's also the possibility that a pathogen will invade the catheter and cause a blood sepsis, so we want to prevent this. There are several ways to prevent this. You can either remove the catheter, of course, or you can repair it. And if we would remove it, well, that's not our intention, because we can't endlessly insert catheters into patients. So repair may seem a possible good solution. So there are repair kits on the market already since the 80s. And I've made an animation how this exactly works. We do it in our hospital since like decades. And a dedicated nurse does the repair of catheters at our hospital. And what she does is the following. You have, of course, a damaged catheter. You can see those over there. And well, you can see it perhaps here. It is here inserted into the patient, of course. And what we are going to do is we remove this part and put a new part on the old piece of the catheter. So we cut the catheter in two, and we remove the damaged part. And then you have a new piece that comes out of the repair kit. And you fixate it on the old part that is already in the patient, and then you glue it together, and that's it. It's very simple. And if you want more information about this, come to the breakout session at 4 o'clock. I've brought with me a repair kit and also a catheter, so you can see it in real life and real action. So, well, it is widespread used. You've all used it apparently once, at least. But there are hardly any studies about the effectiveness of a repair. And it is also the question, is it safe? So we performed a retrospective study in all our patients between 2006 and 2017 in Nijmegen, in the Netherlands. That's where our hospital is. And we included all tunneled catheters, and that were Hickman type catheters. And the study outcomes were as follows. The question was whether it was effective. And so we looked at the extra catheter life, the extra days you get after you repair a catheter. Then the safety, we looked at the number of blood sepsis that occurred after a repair and within 30 days, and compared that within the 30 days before a repair. And then we also wondered what are risk factors for catheter damage, because if you know what a risk factor is for a damage, you may also prevent it in the future. So here are the results. We included 216 patients who had 527 catheters inserted, of which 477 were never damaged. But 50 were, and of these 50 we could repair 41. And of these 41, 28 were repaired only once, 9 were repaired twice, and 4 catheters were repaired thrice. So in total we had 58 repairs. And of these 58, 55 were successfully repaired, so that was quite a high success rate. And we saw that mostly on the catheter screw thread there was damage, probably because we, of course, connect the infusion systems with the catheter over there. That could be the reason. And we also saw on the rigid and the more flexible junction also damages occur. As you can see, here. So the main outcome, was it effective? Well, first we looked at the time until a repair occurred, until damage occurred. That was after 450 days. So at that point we repaired the catheters. This was on average 450 days. So then we repaired the catheter, and this resulted in extra life of the catheter of 500 days. So we had a doubling of the catheter life with 450 days with an additional 500 days. So that was quite effective. Then we looked at the safety of catheter repair. So we had the 58 repairs. We had the 58 repairs, and we looked before and after the repair, 30 days before, 30 days after, and we count the number of blood sepsis that occurred. As you can see, before the repairs, 30 days before, we saw in total 2 blood sepsis occur. After the repairs, we saw as well 2 blood sepsis occur, so it was identical, and there was no increase in blood sepsis, so it was safe. And then we looked at risk factors for catheter damage. And what we found was that the younger age of the patient was a risk factor for catheter damage. And we think it might be the cause that patients have perhaps a more active lifestyle and therefore are more prone to get a damaged catheter. And the other risk factor was having a catheter in the leg. And we think because, of course, people bend their legs while walking or sitting, it may also bend the catheter and therefore cause the damage. So to conclude, we saw that the catheter life was doubled with a repair, so it was effective. And we saw also that catheter repair was safe because there was no increase in blood sepsis. And there were 2 risk factors for catheter damage, a younger age and having a catheter in the leg. So our take-home message is that if you have a damaged catheter, consider repairing it and don't remove it. Thank you for your attention.
Thank you, Yannick. Does anyone have any questions? I know somebody was saying something about getting the catheter repaired. Yes.
Wait for the mic. We're live streaming. Can't hear without the mic.
Okay. In the slides, you had mentioned that you had studied the catheters 30 days before and 30 days after in need of repair. If you had studied the catheters 30 days before they were repaired, I trust that even though it was 30 days before, they were still in need of repair at that time?
Sorry, they were?
If you studied them 30 days before,
Yeah.
there was damage 30 days before, so they were in
No,
need of
at
repair?
that point, there was no damage yet. So that was 30 days later. So we looked 30 days before the repair, so there was no damage yet. And we looked at the blood sepsis numbers.
Oh, okay. I was just wondering why the patients waited 30 days to get their...
No.
Okay.
No, that's a good question indeed, but the damage was 30 days later.
Oh, okay. Okay, very good. Thank you.
Any other questions? Yes.
I just have a question. I have a 3-year-old that runs everywhere with his line, and often it breaks because he's moving too fast. And in Canada, they repair it like very often. Is it safe to repair the same line like twice or third time, or it's better just to repair it once?
I think there's no, you can repair it as much as you want because we see it is effective and it is safe. So yeah, as you can see from the results, we had catheters already in place for with repairs for already 3 times. So that is possible, yeah.
Thank you.
And I guess one of the advantages too is of repairing it is you can't always use those veins again on a regular basis. So the lines should be repaired rather than removing them as so many locations do for infections. You've got some over here.
Do you put a little metal piece, a stent between two?
Yeah, you didn't see that on the animation, but yeah, if you come to the breakout session, you can see indeed a metal stent. It is for extra, to give it more strong.
Which I've never seen before.
Fixation. Yeah.
More of the doctors need to know about these repairs because my daughter was in the hospital, the local hospital, for a week, and they told us they would not do a repair because their malpractice wouldn't pay enough.
No, it is very easy. You take your manual, of course. You have to read it and.
My daughter brought it up on YouTube and showed it to them, and they said if we get a kit, then we will do it. But they never got one. She was sent to the University of Penn, and they said, well, it's not an emergency. We'll wait. This is Friday. We'll wait till Monday to do yours. She says my potassium is at 2.9. If it goes lower, it'll be an emergency, right? Within an hour, they had her down to repair it. And the doctor that put it in was there. And he just happened to come in. And she was going to teach the interns how to do it. And he says, I'm going to do this. I put your line in 3 years ago. This person does not have any other veins or any other vessels. So we want to preserve this as much as possible. I'm doing the repair.
Yeah, that's a true story. Yeah.
I'm sorry, we really don't have time to take any more questions. I just want to rapidly.
We should direct them to his breakout session.
Yes, breakout session this afternoon.
Yeah, 4 o'clock.
Okay. Just quickly, I will tell you that the third person to win this is Dr. Tribler Siri from Denmark, Copenhagen, and the title of the talk was Catheter-Related Bloodstream Infections in Patients with Intestinal Failure Receiving Home Parenteral Support Through a Subcutaneous Tunneled Central Venous Catheter. So, and I'm not going to present the paper.
Go ahead. Oh, go ahead.
No, I think you have something else to do.
I do. Thank you for sticking with us this morning. I want to make one quick remark while I invite Oley board member Beth Gore here and I get Bob and Mary situated to hold the candles. One quick announcement. One of our young members, his name is Chase Beek, he won the bid to be the Oley Duckmaster today at 5 o'clock. He is thrilled to death, and I know many of you will be in a breakout session, but if you could just get to the railing and just cheer him on, it'll be the most rewarding experience, honestly, ever. So we now start a portion of the program where we honor Oley members who have passed on. And you'll notice there are candles in the center of your table, and we have 2 people here and 1 on each side. They're under the chairs? Oh, if they're not on the table, they're under the chairs. It's the hide and seek portion of this morning. Find your candle, and then if you could make your way 1 table at a time, light 1 person from your table, assign it, it's an important job, and then 1 person from the table comes here, lights their candle, return to your table, and light the other candles as we begin the ceremony. And Beth, thank you very much. Beth, go on.
Do you want to start with getting the candle people down, or at the end? As you get started on this candles, I'm going to tell a couple stories. My grandmother used to say to me that the day you give birth to somebody, you also give them death. And I remember thinking, that's kind of morbid. And the older that I got, the more I realized what that really meant. Is sometimes in America, we don't want to talk about death, but it happens to everybody. And yet we still don't feel comfortable with the concept. And yet people in this room are probably more familiar with this concept than the average person. And we have all lost people, whether it's to Oley kind of conditions or not. 9 years ago today, a little boy was born. And we adopted him a few months later. And we were told he wouldn't make it to his first birthday. And so today he celebrates his 9-year-old birthday, and he is here with us today. So you just never know. But that little warning is always there, that little moment that just says he still has a fatal condition. And I know you guys all know what I'm talking about today. So today, we are honoring those who are alive, and we are honoring those who have lived. I'll read a couple of passages that have been highlighted. It says, when I come to the end of the road and the sun is set for me, I want no ceremonies in a grief-filled room. Why cry for a soul set free? Miss me a little bit, but not too long, and not with your head hung low. Remember the things that we once shared. Miss me, but let me go. For in this is a journey that we must all take, and we must each all go alone. It is a part of a master plan, a step on the road to home. When you are lonely and sick of heart, go to the friends we know and bury your sorrows in doing good deeds. Miss me, but let me go. Another one is, the tide recedes but leaves behind bright seashells on the sand, and the sun goes down, but with gentle warmth it still lingers on the land. The music stops, and yet it echoes in sweet refrains. For every joy that passes, something beautiful remains. Two more. We can shed tears that she is gone, or we can smile because she has lived. Our hearts can be empty because we can't be with her, or we can remember everything that she shared. Or we can only think of our time with her in the past, or we can be happy for tomorrow. Because of all that we've learned from her, we can remember only that she is gone, or we can cherish the memory and let it live on. And we can cry and feel sadness, or we can do what she would want, and that is to smile and love each other and go on. And I'll leave you with one last thought, and that is, our knowledge has been greater, our love for others has been deeper, our lives have been fuller because we shared some time with them.
in this room, Oley's theme is help along the way. And that means from the beginning all the way through the end. So as we pay tribute for the losses, we remember them. We remember who they were, who they are, and remember those who are in the room. And so thank you for honoring these people with us today.